Good morning, all. Bright, sunshiny day. Happy day. Welcome to Labor and Health. We're going to forego doing roll because it's continuation of yesterday, and the only addition today is we've got Senator Dockstetter here. Welcome, Senator Dockstetter. We're happy you could join us. Today, we are going to talk about essentially three subjects and then do some agency updates. We're going to start off this morning with prior authorization. If I can get LSO to come forward. And lead us off, and then we'll drag some other folks up here. Welcome, Anna. And you're smiling. I know it's that first thing this morning. Anna was happy this morning, so we're all happy to be here. Go ahead.
Good morning, Chairman, members of the committee. Anna Johnson, LSO. I have a fact sheet here regarding prior authorization and legislation in other states. This fact sheet is just meant to give a brief overview of recent legislation from other states regarding the prior authorization process. I'm just going to give you the highlights of the fact sheet since many of these statutes tend to be pretty repetitive. Prior authorization is a process through which healthcare providers obtain advance approval from health insurance providers before a specific medical service is provided to a patient. In Iowa, their statute prohibits the revocation or limitation of a previously approved prior authorization after the service has been provided, subject to exceptions such as waste, fraud, or abuse. In Louisiana, every health insurance issuer authorized to do business in the state is required to implement a program that allows for certain healthcare providers to submit to reduced prior authorization requirements. Louisiana also has a universal prescription drug authorization form that can't exceed 2 pages and that must be used. Health insurance issuers can be sanctioned for not using the form. Louisiana also requires that if a healthcare provider requests prior authorization requirements, they have to be furnished within 24 hours of that request. And if a prior authorization request is denied, then notice must be given within 3 days. In Michigan, that state requires a process for prior authorization requests to be handled electronically with an electronic portal. And denials of prior authorizations have to be made by a physician, or if it's a prescription drug, by a physician or a pharmacist. If a prior authorization isn't urgent, it will be deemed approved if the insurer does not notify the healthcare provider of a decision within 9 days of the request. And if it is deemed urgent, it will be deemed approved if a decision isn't made within 72 hours of submission of a request. New Jersey has some proposed legislation that provides a thorough definition of medically necessary when it comes to prior authorizations. In that legislation, requirements for prior authorization requests must be posted online and be readily accessible. And if a healthcare provider certifies that a person requires emergency healthcare services within 72 hours of a person being admitted to the hospital, this would create a presumption that the services are medically necessary. If a person receives treatment for a chronic or long-term condition, then they only need one prior authorization for the treatment rather than having to go through the process over and over and over again. New Mexico requires a standard prior authorization request form and the use of an electronic portal for request submissions and to do appeals for denials. Health insurers who do not comply with prior authorization requirements are given 2 warnings in that state, and then they may be fined up to $5,000 for non-compliance. And then finally, in Texas, if a healthcare provider has had 90% of their prior authorization requests approved during the previous 6 months for a particular healthcare service, then health insurers may choose not to require them to request further prior authorizations for that particular service. And with that, I would stand for any questions.
Questions for Anna, committee? We have a lot more information to come, so this is a preliminary. Okay. Oh, one question. Representative, go ahead, Representative Pan.
Thank you, Mr. Chairman. Do you know on any of these what their definition of urgent was, or like who deemed who was the person that deemed it being urgent? Was it the provider that was deeming it urgent, or was it the insurance company that was deciding if they thought it was urgent?
Go ahead, Anna.
I am not entirely positive on that particular issue. I don't remember seeing any definition of urgent in any of this legislation. I can definitely look into that, though, if you'd like me to.
Okay, further questions, committee? Representative Clausen, go ahead, sir.
Thank you, Chairman. Thank you for being here and this work you did. As you did your work, Wyoming is the only state that doesn't have prior authorizations. Do you know which other ones were more recent?
Which other ones had more recent legislation?
Yes, thank you.
So these states that I looked at, for the most part, those tended to be the most recent ones with legislation, prior authorization legislation.
Very good. Okay, thank you very much.
Thank you.
Everybody's anxious to come up here. Look at everybody saying, who's he going to call on next? Let's go ahead with this one. Let's bring the insurance and the Department of Health up at the same time, if we could. There's 4 seats. There's only 3 mics. They'll have to share. And Fran's going to have to pull a chair up. We're going to go to my left to right. Let's start over here with the director, please.
Thank you, Mr. Chairman, members of the committee. Stephen Johansson with the Wyoming Department of Health. I know the topic you're considering today on prior authorization is much broader than just the public payer or Medicaid space. We did provide, as part of our macro presentation to you all, starting on slide 14, just some brief overview of what prior authorization is. Mr. Chairman, for the sake of expediency, we don't have to go through everything here. But really what prior authorization means for Medicaid is there's certain services, certain things that Medicaid covers that we do prior authorizations on for a couple of reasons. One, it might be federally required by CFR. 2, over the years when we've seen utilization and overutilization in certain types of services, we will put administrative processes in place to make sure that a physician or a nurse or a clinician reviews those for medical necessity. So there's a variety of reasons why Medicaid might implement prior authorizations. The pharmaceutical space is another good example where we have over the years seen some very expensive drugs, for example, that get added to the formulary and things that we cover, but require certain things that need to be completed, or a plan in place, for example, with hepatitis treatment where multiple administrations of the medication are necessary, and we want to ensure that that treatment regimen is followed. Often we'll use the PA or the prior authorization process to review that. Mr. Chairman, members of the committee, on slides 17 and 18, just a little bit more background on why we do that, sometimes to control fraud, waste, and abuse, and other times to prevent inappropriate utilization before it happens, and really using it as an educational tool. We certainly don't do PA on everything, but like I mentioned, some select services, which you can see on slide number 18. Certain outpatient behavioral health, certain physical therapy, occupational therapy services, inpatient psychiatric admissions, we do prior authorizations in Medicaid on, as well as psychiatric residential treatment facilities for youth. Home health services, skilled nursing services, transplant services, certain types of DME or durable medical equipment, and as I mentioned, select prescription drugs. And I believe we cited the CFRs where the federal requirements are on slide number 16. Happy to provide the committee with a list of those that are part of the rules for states that operate Medicaid programs. And then you can see on slide number 19 some of the statistics on those services that were on the previous slide, the number of reviews we conducted in a fiscal year, and the percentage of denials on those services. Use that as an opportunity, Mr. Chairman, to mention that on the select services that Wyoming Medicaid does prior authorizations on, We try to do continual reviews on what we're seeing with prior auths and the percentage of approvals and denials so that we know or can make changes. For example, if we see 99% of prior authorizations going through very speedily and there's no issues, maybe it's time to kick that threshold up or remove the prior authorization altogether. A good example of that from recent years, when we saw a little bit of a budget strain and some inappropriate utilization on the behavioral health side, we implemented a prior authorization for outpatient mental health where there was a soft cap of 20 outpatient visits per year, and then a reauthorization demonstrating medical necessity was necessary. Over about 18 months, we saw really good compliance with that prior authorization. So we made the decision to kick that threshold up to 30 visits per year. And we're actually, especially on the adolescent side, in that same boat again, where Mr. Grossman and I are reviewing if that prior authorization requirement needs to be adjusted and making sure that we're not just putting administrative barriers for the sake of administrative barriers on providers. With that, Mr. Chairman, I'll reintroduce you to Lee Grossman, who is our newly minted state Medicaid agent as of February. You met him during the session, but I know you guys had things to do and things on your mind. So I'll hand the mic over to Mr. Grossman just for any added color commentary on prior auths from his shop in Medicaid.
Thank you, Director. Mr. Chairman, members of the committee, Lee Grossman, Wyoming State Medicaid agent with the Department of Health. Pleasure to be here with you this morning. I'll keep it relatively brief and add on just a couple of additional details to what you've already heard from the director, and more so from the process perspective. So this is a function that is contracted out, and this is currently with a company called Telegen, with which the department contracts to perform these functions. In the slides provided, you can see the types of clinical expertise that Telegen has on staff. That's on slide 16. But from a process perspective, this is an all electronic process. I know we heard earlier about how some states require that, so this is submitted through an electronic portal. From a contractual perspective, depending on the service, Telegen has to turn those prior authorization requests around anywhere between 1 to 3 days at most. And let's say there's more information needed, there's a process by which Telegen will request that from the provider. They'll have 3 days to get it back to us, so that way we can turn around again that approval to them. We see a 96% compliant rate with our contractor of meeting that 1 to 3 day threshold, so feel pretty good about their response. And of those denial reasons, the denials that you see on the last slide that the director already pointed you to of the various reviews and denial rates for that data that we do at the Medicaid agency on slide 19. Roughly speaking, just globally, 2/3 of those denials are due to technical reasons. So for example, different documentation was needed. Perhaps the person wasn't even eligible or the service didn't even require a prior authorization. The other third would be for that clinical criteria or medical necessity criteria that those clinical experts listed on slide 16 would be performing. So I hope that's just a useful additional commentary from a process perspective of what that looks like for us at the Medicaid agency. And with that, I believe we'd be happy to stand for any questions from the committee.
Good, let's go ahead and take one more additional person from the Department of Health, if he's got anything to say.
Mr. Chairman, Franz Fuchs, Policy Analyst, Department of Health. I'm just here to look good. Thanks.
And you're doing very well, Franz. Thank you. Okay, let's go ahead to the director and go ahead, and then we'll ask questions of all of them. Go ahead, sir.
Mr. Chairman, Co-Chairman, committee members, my name is Jeff Root. I'm the Commissioner for the Department of Insurance. To my left is Jill Reinke, our Senior Health Policy Analyst. She's sitting behind me because if she sat at the table, she'd have to get coffee from me. I'll touch base just a little bit on prior authorization from a non-Medicaid program standpoint, just from what we see. We have not had many complaints on pre-authorization. We see it in conjunction with a determination of medical necessity, and that's what is in the statute, and we have that in the statute now. And so what we will see is the process is spelled out. where someone will want to have their knee repaired. Their doctor will put in a request for prior authorization. If it's granted, great. If it's not, because it's not medically necessary, maybe they didn't do physical therapy first, there's other courses of treatment, it'll be determined not medically necessary, and it goes back to the doctor and the consumer. That individual then is told that they have the ability to ask for an appeal, an internal appeal to the insurance company. And so it goes to the insurance company, and there's an internal appeal to a medical doctor who will look at it and say, it's either medically necessary or it's not. If it's not if they say it's not medically necessary, then they're also, the consumer and the doctor, they're working with the consumer, is notified that they have the right to a independent review organization to reveal it, to appeal it. So it go outside of everybody's sphere of influence. Our office keeps a tally of 10 or 12 IROs, independent review organizations, and it would come to us, and we just go down the list, and we did number 7 last time, number 8 gets it now, and all the documents go there, and then they will do their review. And if it's medically necessary, they will say so. If it's not, that's the final opinion. This is all spelled out in statute. It's all spelled out in the consumer's policy. Generally, we've seen 20 of these per year that have gone to the request for an independent review authority. And in about 40% of those cases, it's determined to be medically necessary, so they're siding with the consumer in that case, and then the procedure is paid for. So that's what we see. We don't see many complaints on it. We just haven't. It doesn't mean they're not out there. We just have not seen them. The only other thing I'll touch base on, just because it hasn't been said, is in the background of all of this is the No Surprises Act, which was passed last year, which prevents direct billing to consumers for emergency care and air ambulance costs and things like that. And so, for example, in the instance someone's getting their knee, a meniscus tear repaired, they've scheduled it 3 months in advance. Well, they don't know who the anesthesiologist is on that team in the hospital. They rotate. And so a week before you might know, and they might be out of network. So years ago, that consumer who thought they were in network going to the hospital, who is in network, has an anesthesiologist as part of the surgical team who's not. And we would hear complaints we'd see complaints of being balanced bill for those services. We don't see that anymore with the No Surprises Act, and we have not seen that. Same thing with their ambulance and the surprise billing there. We just haven't seen those. So that's what we've seen from our perspective, and I would stand for any questions.
Very good. Anything to add? Go ahead.
Thank you, Mr. Chairman. What's the citation on the medically necessary, just so I can?
Mr. Chairman, Senator Barlow, 2640-201, and then into 20 and thereafter. So.
Very good. Okay, committee, questions for the group? If they're anxious to answer your questions, go ahead, Representative Ward.
Thank you, Mr. Chairman. On slide 18, I think this is for Director Johansson, it says that certain Medicaid services require prior authorization, and one of them is selected prescription drugs. So my question is, suppose there are well-studied, inexpensive prescription drugs like ivermectin and hydroxychloroquine. Do those require pre-authorization? Did they require pre-authorization in the past 2 years?
Director.
Mr. Chairman, Representative Ward, my understanding on those drugs is no. I don't know if we have Dr. Cooper on Zoom. If we do, Mr. Chairman would ask to bring her in, maybe provide a more detailed answer, but I do not believe those drugs were PA'd.
Further questions for the group? Thank you for pointing that out. If you see somebody on the other side of the room, wave at them. Representative Payne, go ahead.
Thank you, Mr. Chairman. I have a few questions. First for Director Johansson. Where did I write that one down? You mentioned that if you were seeing that there were a lot of prior authorizations that were pretty constantly getting approved, that you were taking the prior authorization off or changing it or something. Were you talking about just all requests in general, or are you talking about specific providers? So if one provider, most of their prior auths get approved, because I saw that in one of the in the memo that other states have done that for specific providers. How does Wyoming work?
Mr. Chairman, Representative Penn, that's a good question. This would be related to the service, not an individual or specific provider. But it's a good question because I think it's important to, we got to strike the balance in Medicaid on the things that we have control over that we don't have to PA by federal law or federal rule. Then we typically look at that on a system-wide basis. So statewide for all of the providers that are able to provide that service, for example, outpatient mental health, we would look at that as a kind of a systemic whole, but for that service, not provider specific. But we do, Representative Penn, Mr. Grossman and his team, we try to do the best we can to offer technical assistance to providers, especially on those process and technical ends that a lot of times the breakdowns we see are maybe we've not communicated how the process works as well as we can, or that there's issues with submitting the paperwork and what documentation is required, and we try to do hands-on service for those providers to the extent possible to educate on the process.
Good. Follow-up? Go ahead, Representative.
Thank you, Mr. Chairman. Mr. Grossman, I have a question for you. You had mentioned that Telligent has typically a 1 to 3 day turnaround. Is that for everything, or are there some things that they have longer timeframes? I was just noticing in the examples that we were given before, they were talking about 9-day turnarounds and things, which to me seems pretty excessive, but 1 to 3 days, is that, just comment a little more, please.
Go ahead, sir.
Mr. Chairman, Representative Penn, that 1 to 3 days is, so 3 days would be the maximum essentially for any of those services listed. The reason I say 1 to 3 is because we have that specified if it's 1 or 3 days based off of the services that you see there. So three would be the high water mark in terms of the response time that Telligent is required to offer.
Thank you, Mr. Chairman. I missed your last name. Okay, thank you. So my question for you was talking about the reviews, the internal reviews and such. Who makes up those committees? Who's actually doing those reviews? Like, what's the makeup of those?
Commissioner.
Mr. Chairman, Representative Penn, when you say the makeup of who's reviewing them, when I said independent review organizations, it's really a person. It's a doctor that has done this, that we look at their credentials and they're put on the list.
Okay. Further questions, committee? Go ahead, Representative Horno.
Thank you, Mr. Chairman. You said there's about 20 of these per year. How many total? Or 20 of these are denied per year, I think. So how many in total do you see on average?
Mr. Chairman, Representative Hornak, we will see 20 or less, it's actually been 18 and 19 in the last 2 years, formal requests for an independent review organization or individual. Of those 18 or 19, about 40% will be found in favor of the consumer. What we don't see are instances where the initial review goes back to the insurance company that have the internal review. Because if they can, their medical doctor at that point can say, oh, no, it's medically necessary, and change it, and we have no visibility of that at all. So we only see less than 20 per year going through the entire system where they're denied as being not medically necessary, and then there's a request for the internal to the insurer, and then that's denied also, and then there's the third, the external review.
Okay, follow up, Representative.
Yeah, thank you, Mr. Chairman. So there could be hundreds or thousands of these PAs that actually kind of go through without going through that process down to this level or up to your level.
Go ahead, Commissioner.
Mr. Chairman, Senator Harnick, yes, absolutely. I just don't know the numbers. It's possible that some of the folks in the room actually have their numbers for how often they see them and they're dealt with and approved.
Mr. Co-Chair.
Thanks, Mr. Chairman. Commissioner Rude. So your office, you do on IRO, you say it is medically necessary. What happens at that point? You contact the insurance company who has already said we're not going to review it, and you say, well, our doctor says it is. Can you walk me through that process? I mean, do you strong arm the insurance company at that point and say, we made a decision in favor, and they say, okay, and they roll over, or what happens after that?
Mr.
decision?
Co-Chairman, once that last determination is made, it's done. They comply.
They comply.
Or else. Or else what? Further questions, Representative Young.
Thank you, Mr. Chairman. Mr. Grossman, or maybe Director Johansson,
For the contract with Telegen, do we pay them on a per request basis, or is there just like a yearly contract? And so what would be the average cost on a per request basis for that?
Go ahead, sir.
Mr. Chairman, Representative Yen, that's a good question. I believe we'll need to follow up on that information in terms of if that's just an annual contract or if we have any sort of a per review cost built into that.
Representative Clausen, go ahead, sir.
Thank you, Mr. Chairman. Director Johansson, 96% done in 1 to 3 days. I mean, that's great. And it's all electronic, so I think that works really well. Any idea on how many prior authorizations we're looking at for Medicaid?
Go ahead, Director.
Mr. Chairman, Representative Clausen, doing some quick math in my head. It's in the thousands on slide 19. I was remiss and did not include a total, but happy to email that to you. I do have a human calculator over here to my left, if you'd like to ask him.
No, he's just here to look good, that's what I heard. Further questions, committee? Mr.
I
Co-Chairman.
get back, thanks, Mr. Chairman, back to like a 100,000 foot level. So in the public Medicaid service world, you, without statutory authority right now, you think it's working pretty well. I mean, I think where this issue is coming from is really more the hospitals in the private sector, perhaps not Medicaid, but I maybe just wanted to hear you say there aren't a lot of complications without us having statutory direction. You're still making it work, or are there places you think we probably do need a statute and it would clarify some things for you?
Director.
Mr. Chairman, Co-Chairman Zwanitzer, yes, I would characterize it as without statute change, this works relatively well. Now, providers and individuals behind me or in the communities might disagree. It's always a back and forth with a payer, and Medicaid's one of those, on how the process should work, what should be PA'd, what shouldn't be. And we serve multiple masters in Medicaid, federal government, you all, our consumers, our providers, and so we try to strike that balance. So I don't think any statute change is needed for us to operate in the way that we've been doing. I will mention that later in the agenda, we have a very small request for a statute tweak on the third-party liability component, which isn't a prior authorization issue. It's how Medicaid chases payment from other insurances when that insurance should have paid before Medicaid. Some federal law changed in the past 6 months or so. And like I said, it's more of a statute cleanup than anything, but that would be the only thing, Co-Chairman Zwanitzer, that we would bring to this group at this time.
Okay. Further questions, committee? Go ahead, Senator Burke.
Thank you, Mr. Chairman. So Title 26, Chapter 40 is the section that the Commissioner Rood talked about. It talks about a insurer. I guess in the context of this discussion, is Medicaid a disability insurance policy provider? Thank you.
Director.
Mr. Chairman, Senator Barlow, not throwing Commissioner Rood under the bus, I don't know the answer to that, if it's legally and technically, if we're considered one of those providers under Title 26. I'd have to double check and look. I don't believe so, but maybe Commissioner Rood knows, since I'm clearly naive on that.
Commissioner Rood, watch
Mr.
out for the
Chairman,
bus.
Senator Barlow, we don't have authority over them because we don't do anything with them. I think they fit the definition, but we don't have the authority over them.
Very good. Further questions, committee? Seeing none, thank you, gentlemen. Stand by, you may be back. That moves us on to the portion called public comment. Let's go to organizations, perhaps the Hospital Association, Medical Association. If there's any other association that wants to fill the empty chair, please feel free to come up. We'll get you up in a minute if you don't get up now. We're going to go right to left this time. Let's go ahead, Ms. Bush. Introduce yourself and start us off.
Good morning, Mr. Chairman, members of the committee. Sheila Bush with the Wyoming Medical Society. I'm eager to talk about this issue with you. It's a top priority for our members. Just as a reminder, we represent Wyoming's physicians and PAs across the state. And so in terms of complaint, this is probably one of the #1 phone calls I get as an organization representing them, is their frustrations in trying to care for their patients. And so I think there are a multitude of aspects that we could have this conversation. I think that when you place an entity like an insurance company between a physician and their patient and try to tell a physician, despite their medical knowledge, their relationship with the patient, their understanding of the patient's situation, that the physician's determination, diagnosis, and treatment plan is not the right one without knowledge of that patient and their situation, asking physicians to continually on a daily basis defend their medical judgment and what they've decided has a pretty significant toll on the medical profession broadly. And when that happens day after day and year after year, we talk a lot in this state about recruitment and retention, keeping physicians here. I think that components like this are a major driving factor of burnout and them finally deciding that it's just not a profession they can stay in. I provided a number of documents that were made available to you, so I won't go through all of those, and I'll ask your forgiveness, but I did want to just sort of go through some of the really, I think, staggering statistics associated with prior authorization. And this was provided to you and with the citations and those kinds of things. But quickly, 94% of physicians report care delays because of prior authorization. 33% of physicians report that prior authorization has led to a serious adverse event for a patient in their care, such as hospitalization, permanent impairment, or death. 89% of physicians see prior authorization as having a negative effect on their patients' clinical outcomes. 80% of physicians indicated that patients abandoned treatment due to authorization struggles with health insurers. And so just abandonment means a patient just gives up. They have a condition, they need help, they have a plan, they can't get it paid for, they don't know how to access resources, and they just stop trying. So I think with that, we have a physician here that will testify after me, and I know the hospitals have a really important perspective on this too. And I anticipate and hope that there are questions and we can have kind of a dialogue about this, but we would just want to stress the importance and ask that you give this a really hard look with us and come up with something meaningful.
Thank you. Let's go ahead and we'll do the whole table and then we'll go to questions. Mr. Boley.
Mr. Chairman, committee members, President of the Wyoming Hospital Association, and if it's okay, I'll let Josh introduce himself and we'll kind of tag team this one.
Thank you.
Mr. Chairman and members of the committee, Josh Hannis, also with the Hospital Association.
And Mr. Chairman, committee members, this was brought to us by our membership, and it's a big issue, not just here in Wyoming, but nationally. It's receiving a lot of national attention. Josh and I just returned from Washington, D.C. this week. We got to be home one day before we got to join you up here. And this was one of the major things the American Hospital Association was talking about. And I'll just share some statistics. These are national, but I think they shed some light on this. 95% increase in staffing for prior authorizations. So we see a huge increase in the cost of healthcare because of prior authorizations. 84% increase in cost because of prior authorizations. There's a 62% prior authorization denial, and 50% of the initial claims that are appealed are then overturned. 7 in 10 hospitals have outstanding claims since 2016. And one of the major areas that I know nationally we're looking at is Medicare Advantage and how it's administered, but we saw statistics nationally where they have high denial claims, and then 80% of those denials are overturned and paid after you go through the process. I think there are 4 components that need to be considered here with prior authorization. Is delaying authorization for patient care. And this is a hospital issue, it's a doctor issue, it's a patient issue too. We have patients that are suffering because of this. And so we're focusing on not just from a financial or an administrative burden, but we're also looking at it from the patient's perspective. Patients are required to try ineffective treatments and therapies before they get their prior authorizations. So you're going to hear about this today. It's called step therapy. So a physician makes a determination of the right course of action to take care of their patient, and then they go to get the prior authorization, then they're forced to go through a whole bunch of different therapies, step therapies, before they can finally get to the point of actually doing what they thought was necessary to begin with. We see denials, obviously, of coverage of medically necessary care. And again, we got insurance companies that are positioning themselves between the physician and the patient and trying to tell the physician how the patient should be cared for. And it places limits on where these patients can receive their care. A couple of other big issues that we find, and one of the issues is that we go through this process, and it's expensive and it's timely to get prior authorizations. We receive those prior authorizations, the patient receives the care, and then afterwards we get a denial, and then we have to go through the appeal process, and we have to wait to get payment. And as I said, we've got some that are outstanding for 6-7 years. One of the things that I think we would like to see as we talk about this is to make sure that if we have a prior authorization, and if we go through that process and we deliver the care, we get paid. And then if the insurance companies want to fight about it, that's fine. But we should have the money in our pockets to pay those claims and take care of our patients. Another thing it's concerning, and it's not necessarily prior authorization, but it kind of goes to that fact, is the look back. Insurance companies have the ability to look back on claims for, I think, 10 years in our state, which is concerning, and then claw back a bunch of those payments. I think it's something that kind of goes along in the same vein. One of the other things that you'll see in some of the draft legislation and some of the ideas that were submitted from the AMA and from us, Medical Society, if you receive a prior authorization for a specific diagnosis and let's say a joint replacement, so you get a knee replaced, instead of having to go through a prior authorization afterwards to get physical therapy, the prior authorization should cover the entire course of treatment instead of having to jump through additional hoops to get more prior authorization to continue the treatment of something that's already been authorized. I think our Department of Health and the Medicaid department did a good job of describing examples of how to simplify this process. And I think in some of the information that you'll see, there are ways that we could simplify this. And we believe that that's part of what's really been happening around the country, is finding ways to make this a simpler process and maybe to eliminate prior authorization when it's not necessary. We'd love to see prior authorization go away completely, but understand that it plays an important role, especially in certain circumstances. But I think there are ways that we can simplify this. You're going to hear from the payers that there are really no problems, that this is a good process, that it's easy, that we have processes in place that expedite this. But the truth is we don't. And we've flown our experts in from all over the country. Okay, we had folks drive in from Sheridan, and we had folks drive in from CRMC to talk about on the ground experience, and you'll hear from them a little bit later. And then I think with the Department of Health, with Commissioner Rood, I think the reason there aren't very many complaints is because as an industry, we've just taken this to be the standard. And instead of complaining to the Department of Health, we just fight it out. But you're going to hear of great examples, many, many examples of the problems that exist with prior authorization. And so we're just asking for some help in simplifying and fixing this. And I'll kind of shut up now and give Josh a chance, if that's all right, Chairman.
Okay, Josh, share your wisdom.
Thank you, Mr. Chairman. I just wanted to offer a couple things before our experts in the field have a chance to share their experiences. My understanding is that the state of Washington has passed 2 pieces of legislation in the last 3 years that I didn't hear in the LSO report that I thought was a solid overview, but just wanted to share my understanding of Washington state's legislation. In 2020, they passed a bill relative to prior authorization that was limited really to data reporting. So their bill required the payers to report on their approval rates of high volume procedures, make accessible on their websites lists of procedures that require prior authorization, so that it's known and transparent and easily accessible. And then just recently, and again, this is my understanding of the legislation, and happy to be corrected if I'm wrong, but in 2023, their legislation, which started out quite broad, was eventually limited to an electronic standardization for submitting prior authorization requests and then receiving the response. And so there's a delayed timeline on that. They have to build out the infrastructure to do it, but the state of Washington has taken these steps. It is the way that I understand it, speaking with my counterparts in that state and reviewing the bill language. And then like Eric said, I think what I'd offer to the group is that a way to approach this is, we have physicians and people that work in hospitals to talk about their experience so that we can understand the current environment and then decide if what's happening today is okay with us. We would argue that it's not. And I think there's ways that we can do better. We've examined some of those. We've offered model bill language that's in your materials. Happy to walk through those after we understand what's happening on the ground and what might work to make a difference for patients and providers.
Okay, committee questions. Senator Hutchings.
Thank you, Mr. Chairman. I'm gonna see if I'm understanding everything you guys are talking about. I had several surgeries last summer with the VA. In order to have those surgeries outside of the VA, I had to get prior authorization to go to someplace else to get these surgeries. Fine with me, because I wanted to go there instead of the VA doing the surgeries. And then with that prior authorization, they also gave me, they do it for 6 months. So anything that happens between the time you get authorized and 6 months, you're covered. Are you saying that the way it happens with you guys, you have to do every step? Like I had physical therapy, my medicines, everything that happened with those surgeries was covered. So I didn't have to keep going back and forth. Is that what's happening?
Ms. Bush, go ahead.
Mr. Chairman, Senator Hutchings, I think what you're asking is a great question, but it also gets to a much bigger thing that I actually meant to talk about, and that is that every single company, every single payer is different. So not only do you have this burden of prior authorization globally on our providers, you also have this additional exacerbating factor, which is every single company can do it differently. And within each of those companies, they can change it at any point within the contract period, right? So a physician decides to be in network, which we talked about yesterday a little. That means they have agreed to the contract with that company to be in that company's network. That company then does have the flexibility to change aspects of that contract. The physician can't, but the company can. And so they're constantly keeping track of which company wants which thing. What do I have to do for this company versus this company? Which is what leads us to this inflation of the healthcare cost in general, because all of our physician offices now, many of them have a full-time person dedicated only to prior auth. Their full-time job every single day is just engaged in these conversations with all of the different companies about what they want and what they need. So each company you may hear from will say, our process is perfect. We do it this way. And then another company will say, our process is great. We do it this way. Well, if you're the provider on that end, and your job is really to take care of patients, and you spend all of your time trying to figure out which company wants which thing and how they want it, it gets to the point where it's unmanageable.
Follow.
Thank you, Mr. Chair. I appreciate that. So what you're looking for is standardization, that the providers all do it the same way. You don't mind the prior authorization. It's just you don't want to have to think about every provider doing it differently.
Mr. Chair. Senator Hutchings, in part, yes. I think standardization is a huge piece. I think we first have to have the conversation about where and when prior authorization is appropriate. We're not here to tell you that it can't ever be used. It's been in place for a long time. There are instances where we understand its utility. We want this to be a conversation that includes balance, and we appreciate that. So I think the first part of the conversation is where and when should prior authorization as a practice be utilized and be okay? What regulation or framework should live around that? I think it needs to be mentioned, and maybe, I think LSO maybe said it, but Wyoming's the only state that hasn't had this conversation. We haven't provided any sort of regulatory framework around what companies can and should do in this area. And then the second piece, once that's decided, is then to say, okay, these are the areas in which we think this is appropriate. Now let's talk about the process. Let's do some standardization.
Sure.
So I think there's two components, and the second has to come after the first.
Thank you.
Mr. Bully, add on.
Mr. Chairman, Senator Hutchins, just a little bit of follow-up on that too. So there's a lot of work that took place in the background that you're probably not aware of to get that prior authorization. And I'm going back to my days as a hospital administrator. I remember a veteran that wanted to get colonoscopy done at our facility in Kemmer instead of driving all the way to Salt Lake or all the way to one of the VA hospitals. And we were within network. It literally took months for us to get that approved for that to take place. And it's preventative healthcare. I'm glad that it worked, and I like the fact that you were authorized for 6 months to receive your entire treatment and care. That doesn't happen in most plans and in most cases. And I think the other thing is there's a tremendous amount of administrative burden that hopefully the patient isn't aware of. But what would have been bad is for you to go through that process and then have the VA say, we're going to look back and say this isn't. We authorize it, but now we're denying it, and then take months for the hospital and the doctor to go ahead and get that payment. And in the meantime, you're stuck in the middle trying to decide what you're supposed to do.
Okay, follow up.
Thank you, sir. Director Boley, I appreciate your comments and I understand full well. And I am so much a braggart of our VA system where I was able to, with one surgery within 24 hours, get authorization for one of my surgeries. And I've never gone more than a week or two for an authorization. They are amazing. Maybe you guys should spend a little time with the director at the VA and see if you guys can get some help. But trust me, I know what you're going through, and more than you know, I know what you're going through. So I hope we can support you on this. Thank you.
Thank you, Mr. Chair. Mr. Boley, so this Wednesday I met with my local hospital CEO, seeing what was on the agenda. I asked him about prior authorization. He says, they have multiple people, multiple departments. Their whole job is to work on prior authorization. So it's a huge expense for our hospital. One of the things he brought up that you just mentioned was the look back. He talked about a recent experience where a diagnostic test, one of the insurers came back and said, for the last 7 years, we've been overpaying you on this test. We need a refund of so many dollars for every test that's been done. So we're talking a huge amount of money. When we look at the look back, instead of 10 years, is there a reasonable time that maybe the Hospital Association has heard from other states that, is it 2 years? Is it 4 years? Is it 5 years? What's a reasonable expectation for a look back? I mean, 10 years seems excessive.
Mr. Boley.
Mr. Chairman, Representative Costin, we've seen it all over the board, but I would think 2 years should be the maximum. A year for the insurance company to make a determination, a year for the hospital to make that repayment. I just don't see dragging it out that long. That'd just be my initial.
Can I ask a question? That question would be, how long is a hospital or a provider or anybody required to keep their records?
Mr. Chairman, I got to reflect on my Public Records Act, but I believe it's 7 years in-house, and then they can be archived. But I'm pretty sure it's 7 years going off of my experience.
Okay. Further questions, committee? Or a voice? I see two hands. Go ahead, O'Hearn, Representative
Thank you,
O'Hearn.
Mr. Chairman. Mr. Bowling, you mentioned people being having authorization and then being denied later, which also goes back to look back. If it's approved on this date and it costs this much money, how can somebody come back 6 months or 2 or 5 or 10 years later and say, you know what, it shouldn't have cost that much, or it should have been denied? Thank you.
Mr. Chairman, Representative O'Hearn. So we're talking about a couple of different issues here, but they're very similar. As far as a prior authorization, that we have authorization, deliver care, usually what happens is the denial comes before the payment. And then we have to go through a whole appeal process to try and get paid. And 50-60% of those are normally overturned. I think one of the other things we haven't touched upon is when there is a denial and when the appeal takes place and when the review takes place, we believe that the correct person should be doing that review. We think that the specialty that they practice in should be the one making sure that the care that was delivered was done in the right and appropriate manner, instead of having someone that maybe that isn't their area of expertise. And that seems to be a big problem. The look back is a little bit different. It has to do with overall claims that are paid, and then they determine it was paid out of compliance with the contract. But again, it's hard to have that liability hanging over you for 10 years to think, well, potentially I could get hit with $1 million settlement or whatever as they look back after 10 years.
Senator Bouchard.
Thank you, Mr. Chairman. You know, I'm a little perplexed because we've heard these same things about clawbacks on the prescription side. And obviously this now affects you as well in a very similar way. Because when they get to use the same kind of PBM structure to say, well, wait a minute, we gave you, or you've put this across your counter, whether it was services or prescriptions out of the hospital. Now they can come back and say, 5 years later, or even 6 months later, wait, sorry, we're not going to cover this. So this sounds like a repeat of what we already went through last session. So I'm perplexed that there wasn't some of that talk about what was happening to you back then, because this is the same problem. Other than on the Medicaid or Medicare side, I mean, I see a split there because the government accounting office said there was $36 billion in money that they caught that shouldn't have been spent. So I don't know. I mean, where do we find the balance there? And I don't want to treat one, Medicare the same. I mean, so we had the discussion just previously. So I'm going to be careful of, we're talking about two different issues. You know, one with a federal spending and one with an insurance provider. So can you also give us some, the committee, some specifics on how the insurance company does it and how the government does it on federal money?
Mr. Boley.
Mr. Chairman, so Medicare is kind of a different animal. However, the Medicare Advantage plans are administered by a third-party administrator, and we are seeing a lot of these similar issues with prior authorizations and then denials and delays, and the numbers are pretty much the same. As far as PBMs are concerned, we didn't weigh into that. This is to a certain degree similar, but it's not. This is a separate issue when it comes to prior authorizations. But the insurance companies have businesses to run. We understand why some of this takes place, but we also believe that there are some major issues with it. I can't really address the Medicare. I mean, CMS is a 1,000-pound gorilla that they have totally different processes really than what we're dealing with commercial insurances.
Representative Yin, go ahead, Representative Yin.
Thank you, Mr. Chairman. So Mr. Boley and Ms. Bush, these positions where their only job is to file and deal with prior authorizations, that work isn't directly compensated by any payer, right? Or any claim process. So essentially, all other healthcare has to help pay for those positions to make that work, right? So when I have an annual checkup at the physician, even though it doesn't require any prior auth, part of my cost ends up paying for those positions. Is that correct?
Go ahead, Mr. Boley.
Mr. Chairman, Representative Ian, yes, that's a great example. They're positions that are created because we have to have them in place, but no, there's no direct compensation for that. And what's good about, I mean, with your example, with preventative care, colonoscopies, some of the other stuff, our insurance companies are really good about saying you need to go get these done, and you don't really have to jump through too many hoops to get prior authorization. But it's the other procedures that do require prior authorization a lot of times, and even honestly, sometimes with the preventative care, you may or may not know that they might have to get prior authorization for those to take place as well.
Ms. Bush, you have something to add on?
Mr. Chairman, not maybe directly in answer to that question, but a thought. When I asked all of our membership to give me their feedback in advance of this committee meeting, I asked, do you have stories, thoughts you want shared about prior auth? And we heard a lot from dermatology. So there's the procedure side of prior authorization, and then there's the pharmaceutical medical medicine side of prior authorization. And one very troubling story that was recurring from all of them that responded in their own way with different stories was this same theme where a patient, and Eric mentioned step therapy, and so it's inside of step therapy, which is sort of a component of prior auth, where a patient has to go through, they're diagnosed with a condition, so maybe atopic dermatitis in a pediatric patient, for example. That's what we hear about a lot. So they have to go through some different medications that are more affordable before trying the really expensive ones. Drugs that are newer to the market are more expensive. And so with atopic dermatitis, the story I got with often, they're forced to try methotrexate, which is very hard on the liver. And I'm looking at you, making sure that I don't say something really stupid. As soon as I do, I trust you'll jump in. And so our pediatricians and dermatologists have said, okay, so they try it, it's not effective. There is a drug on the market that is very effective. It's very expensive also. So what you'll hear and see in step therapy is patients are forced to try and fail the more affordable options before they're approved for the more expensive option. So that's a conversation in and of itself, but then what additionally occurs is once they have been approved, a company can come back and make them retry and refail medications they've already failed. And I think that's where you get real concern and a pretty animated response from our members. It happens sometimes in switching companies. And so a conversation we'd like to have and other states have had about how long a prior auth with one company extends to the next company if a patient has been forced to change companies. It's really hard on people. It's really expensive to make them the same person to try and fail the same medications that we have medical records demonstrating don't work for them, just in an effort to sort of not pay for that more expensive treatment that's newer to the market. And so that's just, I mean, we could spend all day giving these individual examples, but I think that's a really compelling one inside of step therapy that I heard repeatedly. So I think it's enough. I heard it enough to make it worth offering.
Senator Dockstader.
Thank you, Mr. Chairman. Mr. Boley, are you hearing, is this just an occasional instance that was brought up where they're coming back and asking for refunds because a hospital actually applied for something and it really wasn't approved? Are you hearing a lot of instances across the state, or is this just an occasional happening?
Mr. Boley.
Mr. Chairman, Senator Dockstader, are you talking about the look back or the denials of the prior authorization?
Denials. Denials.
The denials?
Yeah.
It's a regular occurrence to have prior authorization denied and then have to go through the whole appeal process.
Mr. Co-Chairman.
Thanks. Questions for this panel or anyone else who's going to testify? Are there certain procedures or specialties or areas of medicine that you find are particularly difficult when it comes to prior authorizations? I mean, I know dermatology was mentioned, but are there just certain fields that you just know that that physician is working in this area of medicine is always dealing with prior authorizations where, let's say like a podiatrist isn't, but a gastroenterologist is? So, or is it just ubiquitous throughout all policies and plans? Nothing gets approved easily?
Go ahead,
Mr. Chairman, Mr. Co-Chairman, I don't have the specific answer to your question. I think I could find it, and so I'll ask. What I would say is I feel like what I heard was when prior authorization was first sort of introduced as a concept, it was pretty limited. It was limited in its application and its utility, and everyone sort of understood it. It might also go to address why you don't hear as many complaints, because through time, now in 2023, it's broadly applied to across the spectrum. There's a lot of examples of, prior authorization being denied for insulin. And that didn't used to be the case, right? They were really limited, and in its genesis, it was intended for very expensive procedures, very expensive medications. It was that sort of stopgap to have some physician within that company talk peer-to-peer with the prescribing physician or the treating physician to say, are we sure? Is this where we're going, right? And now we see it just sort of, there are companies in the news just in the last couple months who have been called out for denying everything. There's a story of physicians who work not in Wyoming, but for a company that does do business in Wyoming, submitting and clicking, they were able to submit, I think, 50,000 claims every minute because they just click and deny. So the practice for some companies has been to deny first and then force that process, because in the process of making people fight it out, some will just abandon it and stop, right? And so it became a very effective way to contain cost. If you just wait people out and make the fight tough enough, they'll give up. And so I don't, your question was, are there certain specialties? I think at one point, if we'd had this conversation, a decade or so ago, I would have had a better answer. Now I think it's so universally applied and it's so broad that it's sort of everyone. Because I think I would have heard from dermatology. And like this time when I sent the email, I heard from family physicians, I heard from pediatricians, I heard, the insulin example came up, and that's just maybe too far.
Further questions? Representative Hornock.
Thank you, Mr. Chairman. So we heard from our Department of Health that there's about 20 or so denials per year that they deal with. Would you agree with their number, or I imagine that specifically talks about like a Medicaid instance, not general medical practice dealing with other insurance companies generally? And then also, so some of the questions related to, the hospital has staff that takes care of these prior authorizations, that they specifically have staff just dealing with these prior authorizations and denials. What do you do as a hospital to help the patients overcome these denials, and talk us through what happens there?
Go ahead, Josh.
Mr. Chairman, Representative Hornock. So we actually have in the room today somebody from one of our member hospitals that this is what she does. And I think she can give you a better answer and explain to you in good detail about how that process works, so that this committee has an understanding of how this is working in the real world. So if that's all right with you, sir, I know she'll address your question. And if I may, Mr. Chairman, Mr. Co-Chairman, on your question about, what specialties are being denied, I think one of the concepts that we've put forward or would put forward is around the transparency in that. You saw Medicaid offered, these are some procedures, it was in the slide deck, and then their percentage of denials. I'm not aware of that in our state, for our state, the payers in our state, what those look like, and we would request that those be made public so that we can have a better policy discussion around, okay, these are being denied frequently, so there's probably a good reason to have a prior auth in place for this. Something's going on, let's talk about it. Or they're being denied very frequently, so why don't we eliminate the practice for this procedure because it's going well in the state and our providers are meeting the standard that they've set in place. So let's not jump through the hoops.
Well, go ahead.
Mr. Chairman and Representative Hornick, to your first question with the insurance department, we just don't report very many. The 20 that they're talking about are the only 20 that have been reported to them, but we're literally talking about thousands of these annually that we just take care of internally. We don't take it all the way up the chain to Director Rood or to Commissioner Rood. And I would say, as far as what do the hospitals do, and I think Josh is right, we need to hear from the experts, but we become their agent, the patient's agent. We end up getting the prior authorization, delivering the care, and then we end up fighting it out for as long as we can to try to take care of making sure that their claim is paid, and after already delivering the care to them in many circumstances.
Further questions? Representative Hornock, follow up.
Yeah, along those lines, and thanks for clarifying that a little bit. It seems like the hospital would then have a financial incentive to do all they can to help the patient with that denial process. I just want to make sure that is happening, because it's been mentioned that, the patient gives up. Well, I understand paperwork can be difficult, but if the hospital's doing everything they can, why would the patient then give up on that?
Mr. Bowley.
Mr. Chairman, Representative Hornick, I think what Ms. Bush was referring to is the fact that the providers give up. The care's already been delivered, and we just get to a point where after we've spent all this time and energy or whatever it might be, we just give up on receiving payment. It's not that, in a lot of cases, then we end up giving uncompensated care to the individuals, but we do our best to make sure that the patients are cared for, obviously.
Okay, without any further questions, oh, there's another one. Senator Bouchard.
Thank you, Mr. Chairman. I just want to go back, Mr. Bull, you said that you didn't weigh in on the PBM issue. Did you not sign a letter in opposition of the PBM legislation?
Mr. Bully.
Mr. Chairman, Senator Bouchard, we did sign a letter, but we didn't provide any testimony, yes.
It was a good thing you didn't hear any of that. We're going to move on to some who can provide examples, and I was saying I'm having flashback. I don't know about Representative Penn, but I know when I go back to my office, I will have a stack of prior authorization requests, as I had a stack that I just worked through before I came down here 2 days ago.
Mr. Chairman?
Yeah, Representative Ward.
Thank you, Mr. Chairman. I know there are some individuals, citizens waiting to testify. Would it be possible after this group for us to let them testify? Because I know they might have jobs and things like that that they have to get back to.
Are they here in the room, or are they online, or where are they at, Representative?
I know of at least one in the room.
Okay, we will get to them here shortly.
Thank you.
Yep. Okay, you can start. You guys fight it out. Whoever wants to start, go ahead and introduce yourselves. And it was unanimous. You're next.
Okay. All right. My name's Nathan Studi. I'm the Chief Financial Officer for Sheridan Memorial Hospital up in Sheridan County. It's been actually very interesting to listen to some of these comments and some of this discussion. Prior authorization is a growing issue for us at our hospital. We, just because I'll bring some of this information, we employ 5 people on the hospital side whose sole job is to get prior authorizations for patients. On my clinic side and the individual provider clinics, it's not uncommon to have 1 to 2 people in those clinics alone whose sole job is just to get prior authorization for patients. You know, the long-term concern for us is that, you know, when you look at this at a national level, we're redirecting vital healthcare resources to administrative work. We hire, we recruit, we go after physicians, and we are having an increased amount of pressure put on our physicians justifying the care they want to deliver. For example, it is not uncommon to have peer-to-peer requests made of our physicians to justify care they want to give. However, we're seeing an increased practice of we have to slot our physicians for 3 different time slots to be available to talk to an insurance carrier, not knowing which slot they will get to actually be able to speak to an insurance carrier. You hear the term thrown out of peer-to-peer reviews. They are not peer-to-peer reviews. Our physicians rarely talk to another physician. If they do talk to a physician, it is not a physician in their specialty. They are talking to either a clerical person or, if we're lucky, maybe a nurse, and to justify their care and their medical expertise on why they want to provide the care that they want to provide. This is a common occurrence. This is not uncommon. We have health plans that we work with where we go through either an online algorithm or an on-the-phone algorithm where we have prior authorization folks who are skilled at doing this administrative side, who begin to move into clinical questions with these carriers. And then after going through those steps, 90% of the time, we move to a peer-to-peer review. And so this is after the practice of it is common for my staff to spend 3.5 to 4 hours on hold waiting to talk to someone. We spend an enormous amount of time looking at these health plans' websites in terms of what they say requires prior authorization. We call because you cannot trust that information, because oftentimes when you talk to the right person, you find out that that care did need prior authorization. So let me take this a little bit down to the patient level. I currently have, in our health system, we have a 14-year-old patient who's been getting treated with Medicaid from a specialist in Billings. The family, for whatever reason, had to switch health plans. We have now had to reach out and contact that physician that they have to send us an order for a different drug, because that drug that that patient has been successfully treated on will not be approved under the family's new health plan, because they have preferred drugs that they like to see. That patient had care delayed, missed one of the Medicaid treatments for 2 weeks, had significant side effects from that. We went ahead and provided the treatment in accordance with the physician's original order, but we are unsure if we'll be paid for that treatment. That's not an uncommon experience. Representative Penn, you said earlier that you said 9 days seems excessive. 9 days for an authorization is a win. We have in contracts that providers or insurance carriers are allowed up to 15 days to provide us a prior authorization. Urgent, emergent, doesn't matter. They get up to 15 days. We have a patient right now in our health system that received care that was authorized in Billings. Patient has come to us and is in our community to receive care. I have to reauthorize that care, and they have to wait while we do that, even though the care was already approved to be received at Billings Clinic. We coordinate a lot of specialty care between us and Billings Clinic because of our community and our location with that area. And so these are common occurrences. We have companies, health insurance plans that are using prior authorization as a means to relocate care. We will be told that we can't authorize this for your use in your facility, but we will have the patient go to one of these facilities in Wyoming that could be up to 2 hours away and require care from a different physician. We have insurance companies that are overly injecting themselves into the care continuum, where they will, a provider, we will authorize certain CPTs for a procedure. Provider will go in and begin that procedure. They need to deviate the care for the best care of the patient. That procedure will now be denied because that's not what was specifically authorized. So all of these things are common occurrences for us. I do want to say that we have a lot of good faith providers or payers in our community that we work great with. Medicaid was up here earlier. None of these situations that I'm sharing with you are our experiences with Medicaid. We work very well with the Medicaid office. We, however, deal with over 100 health plans for people that come through ours, and all of them are different, and all of them will change midstream. We were reviewing a potential policy change that if a patient on a post-retrospective review had care in our emergency department, and that care was later determined it could have occurred at an urgent care or a different perspective, we would be denied payment and we would be held harmed. And so they're trying to continue to insert us into conversations with patients about where their care should be delivered, when those should be conversations between the physician and the patient. Any questions I could answer about any of those examples?
Yeah, questions? I got one on the end down there. Let's go ahead. Senator Barlow. What's that? Oh, Barlow. Bouchard, starts with a B. Go ahead, Senator Bouchard.
Thank you, Mr. Chairman. So I've got kind of two questions. So one, and because I can kind of see where you're going with Medicaid and Medicare, you kind of already see what they do up front. So you know, like, hey, they won't let us do X, Y, Z, so we're not even going to ask them. And I'm being generalized or generalizing that you're not going to ask them to try to authorize something because you already know what they will and won't do. Whereas what I saw similar to what happened with the PBMs situation is that you're trying to get something authorized and they're saying no, and sometimes even after the fact. And so that creates a whole problem in the patients in a turmoil. So come back to the government side. The way they do it is you already know what they will and won't pay for. We're not having that same system on the private side. So they can just have one can do one thing one way, one can do another. The patient is left hanging So I'm trying to clarify how maybe the government system is doing it properly. At least they're telling you up front what they will and won't pay for. And so maybe some clarification, so not just for me, but the whole committee here.
Yeah, it's
Go ahead,
not
sir.
so much in that case of what you're saying there about we know up front what they will do. We have a consistent process with them. And in this case, I'll speak specifically to Medicaid. Then we have a consistent process on how we work with that particular office that is efficient, and we get timely responses. And we know, and then we know that process specifically. And so because it is consistent. And so that's why we work well with that office. And we have other payers across the state that is true for as well. You've got a situation that's continuing to where you heard the testimony earlier where prior authorization does play an important role in looking at how healthcare is delivered, and where it evolved from being this thing that we needed to really make sure we were looking at certain things that were very high cost items or high cost, or is this truly the correct care path, to devolving into things that are universally accepted as this is what you do from a medical perspective. You're going through these hoops to authorize this. It's as simple as like authorizing a colonoscopy, and how that changes to when you're having your colonoscopy performed. If you find a polyp or something is wrong, then that changes what that thing was that's authorized. Some insurance carriers will use that as an excuse to deny now your colonoscopy. I mean, who wants to not have their procedure completed to come back and redo their colonoscopy? Like, I found something, but I want you to, I'm not going to take care of it now. I'm going to have you come back and we'll go through this again. And I've had a couple of colonoscopies, and I don't do them because I like them. So that's not an issue. So I think you've got this overarching step of it's moved away from what it's intended, and it's become, in my opinion, in some payers' minds, this pure thing of this is cost containment for us. And so that is where some of that frustration really comes from. And that's why when I am sharing these examples, these are, Medicaid, Medicare, that's not who I'm definitely not talking about for sure.
Okay. Quick follow-up.
And I shouldn't talk about this since it's personal medical, but I'll just try to be vague. I was in the hospital and they said, we're going to move you to ICU. And I said, why do we want to do that? I walked in here. And they said, well, we want a double dose to get you out of here sooner. And then when I found out, it was because the insurance company said they want me out in so many days. And I said, we ain't doing this one. I'm not going to double dose, so I got to be next to a cart, in case I crash. I walked in here, I'm going to walk back out. So I understand exactly what we're talking about here. And how many times have you heard cases like that where they say, well, we got to try to rush this? And to me, that sounded pretty dangerous to say, hey, we got to double dose you and you could crash.
Yeah, we're fortunate with the medical staff that we have in our community, that's not even something we would listen to if we were told to do that. We have people who are on the floor who are working side by side with physicians. And for us, their clinical judgment at the end of the day is what's going to dictate how long that patient is and what that treatment path is. Have I heard of cases like that? Absolutely. And we do look at things like, and our providers do a great job of looking at what is the average expected length of stay for whatever this particular thing is, and how are we doing with that and the treatment protocols and different pieces. So we look at all those things, but if that may come to me in my office as something that's been denied for payment, but I'm never going to go have that conversation with one of my physicians about that. And you should have done this differently, because you don't want me, my degrees in finance, being inserted into that conversation, nor do I want to be. So.
Okay, let's see if we can move ahead and move down the table. That would be to the middle of the table. Go ahead, ma'am. Introduce yourself.
Mr. Chairman, my name is Beth Allen. I am the Director of Billing Services with Cheyenne Regional Medical Center. I oversee the billing for all of our clinics within our medical group, as well as all of the billing for the facility. We have a team of 12 that do prior authorizations for the medical group and the facility. And they're very busy, and I need 12 more. One thing that we deal with, and you've heard it, and I'm going to repeat it, all payers vary on the method of the submission. Some still want a phone call for prior authorizations. Some want faxes, and some have portals that you can submit things through. Wyoming Medicaid is great. They're easy to submit through their portal, but they do have a different process for medications. Those are faxed. And many of the payers have different processes that they have you follow based on the type of order that you're trying to authorize. On top of that, we talk about commercial payers. It's not, when we're authorizing, we don't only have to pay attention to, oh, this is Cigna and this is their protocol. We have to look at the patient's insurance card and find out what plan type they have, because they are enrolled through a group employer, and that employer may have determined that they weren't going to cover inpatient stays or labor and delivery type things. So we have to pay attention to what plan each patient has, not just the company they're insured through. All payers vary on their clinical guidelines as well that they require to be met before services can be completed or authorized. One of the biggest things that we see, you asked earlier, high-tech imaging is one of the hardest things to get authorized. Surgeries are easier to get authorized than an MRI and a CT scan, which is bizarre, but we see that often. Payers will deny based on medical necessity, even though we did obtain a prior authorization. And when we ask why they've made that determination, where are their guidelines for the medical necessity denial, they will point us to, or that they will state that it's within their guidelines. When we ask for those guidelines in writing, where are they at on your internet page? Where are they at in your policy manual? They can't tell us that. Payers deny claims for failure to authorize, and we had an authorization. The authorization number goes on the claim, and they'll still deny it, saying you didn't authorize this procedure. So we spend hours on the phones. I had one on Tuesday. I spent an hour and a half on the phone with Cigna, with the representative. I was on for 30 minutes. She put me on hold. I got disconnected. I had to call back. Went through the hold game again, and luckily I got the same representative, and she remembered me and was able to get right back to business with me on that claim. But ultimately, it was a newborn baby that had some complications, had to be in the NICU for 10 days. We did get an authorization from date of birth to date of discharge. For whatever reason, Cigna denied 5 of the 10 days for authorization. So I spent an hour and a half on the phone. They are going to reprocess the claim, and I get to wait and sit back 30 to 45 days to see if they pay it this time. If they don't, we start the process again. There is no set time frame for payers to respond to prior authorizations. He said 9 days we consider short. Honest to God, in some cases we do. We have payers that are taking 3 to 4 weeks to give authorization approvals on what we deem as emergent or urgent cases. One of the representatives asked earlier, who determines if it's an urgent or emergent? The provider does. We mark on our prior authorization submissions, urgent or emergent or normal care. So they are supposed to, in turn, prioritize based on how we're putting those authorizations in based on the order. But again, there's no time frame. We spend a lot of time calling, getting on their portals, checking on the status of the authorization we submitted 5 days ago. It impacts patient care. It delays patient care. It impacts what is important to hospitals, our patient satisfaction scores, because guess what? Our payment is driven more and more on our patient satisfaction scores. Patients can have procedures done prior to us having the authorizations, but in turn, they have to agree to sign a financial letter stating that they understand they're doing it without prior authorization on file, and they could ultimately be held liable. They'll sign that letter. We provide the surgery or procedure. We get it denied. We will send it to the patient, and then the patient is on the hook for that balance. And, arguing with us, even though they signed a financial letter saying they understood they were doing it without knowledge of whether or not it was going to be covered. And it's a double-edged sword. Payers vary on whether or not they'll permit retro authorization. So, we're a hospital. We are open 24/7. We have patients that'll come in on Saturdays, Sundays, middle of the night, holidays. We aren't staffed 24/7 in the prior authorization role. It's an administrative function. And we are often having to submit retro authorizations. So after the fact the patient's been admitted, or after the fact the patient came in with a trauma, had to have surgery. A lot of payers will not accept retro authorizations. They tell us just submit the claim, and if it denies, appeal it. Well, time is money, and what sits on our accounts receivable the longer it's on there, the harder it is to collect. And so we're just doing a lot of pay and chase, and trying to get reimbursement for services that were rendered. Continuance of care for patients when insurance is changed, that's been talked about today. And I can tell you, I've been dealing with a gentleman with cancer who was insured through his wife. She was a school teacher, so they had Blue Cross Blue Shield through the district. He is retired military, so he had TRICARE as his secondary coverage. He was taking an oral chemo, and Blue Cross Blue Shield required that it go through their specialty pharmacy. So the specialty pharmacy would mail the oral chemo to the patient's house. The patient would take it. The gentleman's Blue Cross Blue Shield termed because his wife retired, which then jumped TRICARE to be primary. What has happened with this gentleman is that he's received a pay and demand letter from Blue Cross Blue Shield for the $15,000 for his chemo pills for the month of November, because his insurance had turned with Blue Cross, but Blue Cross's specialty pharmacy had made the error and not checked the eligibility and went ahead and mailed the drugs. The patient took the drugs. The patient has been trying to get TRICARE to pick up the cost of those drugs, and TRICARE is saying no. So I have spent time on the phone with our TRICARE representatives, our Blue Cross Blue Shield representatives, the nurse practitioner that's treating him, and trying to get TRICARE to even agree to just cover portions of it so that this gentleman doesn't have to pay the $15,000. The pushback we're getting from TRICARE is that Blue Cross Blue Shield had authorized capsules. TRICARE will only allow tablets. So we're literally talking about the form of the drug. We're arguing over the form, capsule versus tablet, and the gentleman's on the hook for $15,000. That kind of stuff happens all of the time. Everyone's standing around, the payer's pointing the finger at the other one, and ultimately the patient is the one that's suffering, as if he doesn't have enough medical bills treating cancer. Payers often vary on the length of time approved for ongoing treatments. Botox is a big thing for us. It's an expensive drug, but it is a very good treatment for migraine sufferers. And insurances are varying on, one payer will authorize it for a month. Another payer will authorize that treatment for 3 months. Another payer will authorize said treatment for 12 months. So it's just a constant keeping track of the authorizations. And then we have the cancer patients and infusion patients, chemo and radiation oncology. That one is really difficult. It's very expensive. It's very time consuming. It really requires a lot of clinical background when you're submitting those. So we've even moved our prior authorization person physically into our cancer center so that they can grab the provider walking by whenever they've got a question that they have to be able to answer on the drugs and the chemo regimen that's been ordered. The other thing that's difficult for chemo is that the treatment plan changes constantly. The providers have to stop this medication because there's an adverse reaction, change another one. They're changing the number of micrograms that they're giving, the number of times they're giving it. Whenever those plans change, we have to resubmit and get authorization all over again. And then the drugs themselves, we've got an authorization on file for this drug. Then we have an authorization on file for this drug. This term is for 3 months. The term for this one is 12 months. And we're having to determine back in the billing department which authorization number goes on the claim. And errors are made and we're having to refile things regularly. I would like to point out one thing that was mentioned about Medicare Advantage and replacement plans. They are picking and choosing what Medicare CMS guidelines they're following. What ones are beneficial to them, they follow. The ones that are not beneficial to them, they don't follow. So something needs to be put in place in general with the Advantage and replacement plans so that they can't pick and choose what they want to do. And the last thing I'd just like to say is that we talked about look back periods and that providers can go back, or excuse me, payers can go back 7 to 10 years and recoup money. I don't necessarily have a problem with that. My problem that we're dealing with is that Cigna, our contract with Cigna is based on a fee schedule. It changes every July. For whatever reason, Cigna can't get it into their system correctly that their fee schedule changes on the 1st of July. So they're paying us on the wrong fee schedule every year. And we have claims that were underpaid from 2020, 2021, and 2022 that we're still waiting to get the reimbursement from. And there's no time frame on that. But there are time frames for us on timely filing, et cetera. I know I've rattled off a lot, so.
No, that's okay. I see a question coming up. Mr. Co-Chairman.
Just a question. So when dealing with some of these companies on the phone, when you say you're from Wyoming, do they know that we don't have the same statutory, I guess, the robust statutes that other states have on when it comes to prior authorizations? Has that ever come up as, oh, you're in Wyoming, let's put you on hold longer, or we'll get back to you? I mean, I guess that's my question. Some of these national companies you work with understand that different states had different regulations, and Wyoming is the one that doesn't have really anything on our books currently. Has that ever come up?
Go ahead, ma'am.
Mr. Chairman, Representative, I'm sorry, my mouth is dry. Representative Zawana, sir. I haven't heard that necessarily. We do have reps from the payers that we will work through. Like we have a Cigna rep, we have Blue Cross Blue Shield rep. And we are meeting with them monthly. And when we have these types of things, we're bringing them to their attention in hopes that they will assist us. But I haven't heard on the phone from a representative, oh, you're in Wyoming. What I do deal with often and my staff complain about is that the call centers for the payers are all over the world. And often you'll get, with Cigna, we get people in the Philippines, we can't understand them. They talk very fast, so you find yourselves yelling at them, repeating things, asking them to repeat things. It's just frustrating, and ultimately, it's either delaying patient care or we're on the back end trying to get paid for the care we already provided.
Further questions, committee? Seeing none right now. Let's move. Oh, I see one now. Senator Hutchins.
Chair, thank you. It's kind of incidental. We were talking about the firefighters yesterday, and they said with the insurance companies, sometimes they will have the payment go to the patient, and the patient is the provider of the payment. Do you have that happen as well? And before you answer, your testimony was very good. All that information is very helpful.
Even with the dry mouth, you did very well.
Yeah, so that is actually in the past has been used as a negotiating tactic to bring contract negotiations because they know the difficulty that we'll have as a provider to get that payment that was due to us from the patient. And so it does happen. From my perspective and what's going on in Sheridan County, it's happened less, but it is a negotiation tactic.
Representative Clausen.
Thank you, Mr. Chair. I just want your thoughts on, we heard from our state Medicaid, 96% of their prior auths are completed in 3 days, right? 72 hours. What's the difference? Why are they able to get everything done, thousands a year back to us, right, in 3 days, and we're waiting 9 to 15 days from the private insurers? So what's the difference in the systems there? And, how do we make these other systems perform as well as our Medicaid's doing?
That's a question you're going to have to ask the carriers in the health plans. I mean, we're working through, and like my colleague over here was saying, that I have over 100 plans I work with. Every one of them's different. Every one of them has a different path on how I get an authorization to perform a service. All of them have different things that they want authorized. I have to authorize this type of surgery here. This one doesn't require it. And so I've been struggling. We've all extended a lot of leniency during the COVID times. And then when we saw staffing issues being so difficult, everybody struggled then. But we're still on the same trajectory we were back then in terms of the timing of turnaround and the timing that we spent on hold, just waiting for someone to talk to us. I can't answer that question on their behalf. I can just tell you it's a pain point. Holly mentioned that she would like 12 more. I am actively evaluating expanding my hospital authorization so I can just get these things done. I'm also looking at the possibility, we run the process, we'll schedule the patient, and we run that authorization process concurrently with the hope that we'll get that authorization by the date that we've scheduled them for their surgery. We're actively evaluating the process of, we're not going to schedule until we get an authorization because we can't get them, we're not getting them back timely.
Mr. Chair, if I could add on to that, to answer that question for us, 34% of our payer breakout, 34% is Medicare and Medicaid. So if you think about that, 1/3 of our patient population has Medicare and Medicaid. The other 2/3 of the population are commercial insurance or self-pay, but commercial insurance. So we have a higher volume of authorizations for commercial payers, number one. Number two, Medicaid and Medicare don't require many things to be authorized. Your commercial payers want authorization for almost everything. So that lies the difference.
Thank you for that. Okay, we're moving down to you, sir. You're on.
Thank you, Mr. Chairman and committee members. My name is Dr. Kevin Helling. I'm a general surgeon here in Casper. Grew up here. I run a solo private practice, general surgery practice. And in that office, where I'm the only doctor, I have a 40 to 50 hour per week employee whose only job is to deal with insurance, pre-authorization, and appeals. This seems to me like a process that was intended to be simple. You've got a particularly expensive treatment or drug, get it pre-authorized. That was 10 years ago. What it's turned into now is a maze that's almost impossible to navigate efficiently, the net result of which is that patients suffer. As a doctor, I get no financial benefit if insurance approves drug A or drug B. Same thing. But what I'm relying on is my 4 years of college, 4 years of medical school, 8 years of residency and fellowship, along with the daily learning that happens in practice to look at a patient, examine them, formulate a treatment plan based on my judgment as a physician, and offering that, only to often hear back from an insurance payer that they don't agree. So this appeals process that we talk about could be the most frustrating thing that I do as a private practice doctor. I do surgery, I do a lot of gastric surgery, I do weight loss surgery. To get a pre-approval for a weight loss surgery, every payer has a completely different set of criteria that has to be met to get pre-authorized. That process could take anywhere from a week to a year. There's no standardization whatsoever with that. And so my staff member has to sort out with that individual patient who needs a service, do they qualify? What hoops do they have to jump through before we can even apply for the pre-authorization? After we do that, even if they give us a pre-authorization, it says at the bottom of the form, we reserve the right to not pay if something comes up. They're like, okay, so it's not even like a binding document that they send us. Beyond that, in situations where they determine that the treatment plan that I've recommended doesn't meet their version of medical necessity, they offer an appeals process. So we basically resubmit the same paperwork that we submitted the first time, along with a letter from me, maybe, elaborating on the clinical circumstances, justifying why I want to do what I'm doing. They almost always say no to that. I mean, my expectation is that they're going to say no. I'm not even sure that they read them. In any event, the next step, I say, can I get a peer-to-peer discussion so that I can talk to another physician about this? Okay, we'll set that up. That involves, coordinating their schedule with my schedule. I've already got a, full clinic and a full OR, but I make the time, I take this phone call. Okay, Dr. So-and-so, who am I talking to? I'm a general surgeon. Who are you? Oh, I used to be a rheumatologist, but I'm retired, and that's the peer that they're getting me. They don't have any expertise in gastrointestinal surgery, none. I also believe that they probably are not authorized most of the time to overrule the denial. Because at the end of this discussion, sometimes argument, they say, well, I can't change it anyways. You can file another appeal for a specialty specific peer. So wait another week, 2 weeks, 3 weeks to schedule that appointment. I think this is the point in the process where many of the patients drop out. They give up, or they travel out of state, or sometimes even to Mexico to get their surgical services because it's just easier. And, it seems like maybe the focus has shifted in the wrong direction from the perspective of the payers, which is just how much does it cost? And they've maybe lost faith in doctors, or maybe they don't care, but they're not trusting that our motivation is to provide the best care for the patients. And we do want to be stewards of the cost of that, and we're all very well aware of that, but we have to do what's medically right. And it seems unjust for someone sitting behind a desk with no clinical expertise or context to overrule our decision, because in the end, the patients suffer. So thank you, committee.
Questions of the doctor? Senator Hutchings.
Thank you, Mr. Chair. Doctor, I didn't get your name.
Oh, so I probably forgot to say, it's my first time testifying at one of these, so.
We just didn't catch it.
Kevin Helling.
Yeah, you did say it. You're off.
You did. Sir, quickly, or maybe, no, use as many words as you want. You all can use as many words as you want. What would you like the legislature to do for you?
Mr. Chairman, Senator Hutchings, thank you for that question. As Sheila Bush mentioned, we're the only state that doesn't have any legislation, overseeing this process. It would be very helpful for me and my physician provider colleagues to have a standardized process and some oversight into how far this process can reach. As I mentioned, the tactic seems to be create so many barriers that most people will give up. Even with Medicaid, they talked about their process, and 20 people a year end up going through that whole process. Well, 40% of them are ultimately approved for the procedure. That means that almost half of those people waited to go through that whole process before they got what was originally recommended and should have been allowed to proceed in the first place.
Okay. Yes, Senator Dockstader.
We're kind of narrowing this down to two problems. What you're describing, you're potentially causing cash flow problems in our smaller hospitals. big ones can probably, they got the pad to do it. Our little guys out there, I can see this causing a problem. But the bigger problem is, when I hear that 9 days is a win, that's ridiculous. We got to step in, put something together, and get it put together for this session. We'll probably bring our insurance friends down to see us this winter. That'll catch their attention, and get this corrected. I don't know if it's as simple as shortening if we call and get put on hold. I don't know if it'll fix it or not. Our co-chair says maybe that's legitimate. But there's two major problems. We've got to fix this for our little guys who are trying to do their cash flow in these little hospitals. It's already hard enough. I see that. I've worked with our little hospital for years. We don't need this extra burden, and we got to serve people better. And if it's some kind of game where we're gonna just push back until we give up and we go to another country for health care, or we just simply give up, that's wrong. That's fundamentally wrong. We got to get it corrected this winter. And do you agree? Thank you.
You can ask a question. The can-do attitude, I like that down there. Further questions for the doctor? I see a hand, Representative Horlock.
Thank you, Mr. Chairman. So in this process, you've got people on staff full-time. Is there any compensation that you receive in the end for those people specifically? So are you allowed to bill out their time during this process? If something is finally approved, can you add that to the cost? Is there, if I don't pay my credit card bill, I'm charged interest. So is there kind of a time frame where there's a penalty on the insurance, or is that just kind of baked into the cake of your overhead and you deal with it that way?
Go ahead. Whoever would like to take that one.
Mr. Chairman, Representative, there's no compensation for the time spent on that. And therein lies a big part of the problem. The longer they make this process take, the more it costs the individual office or hospital. So no, it's all, our rates are all pre-negotiated with the payers, regardless of what steps it took to get there.
Yeah, it's purely baked into it. It's just the cost of doing business. And when you look at and when we negotiate rates, I have to take into consideration that I know this is what my negotiated rate's going to be, but my effective rate is going to be less than that because I'm factoring into what I know I'm going to get denied on and not get paid for in terms of care delivered. So you got your rates that you're negotiating here, and then I'm saying, okay, where do I want to get to here? Because I've got all of this stuff that I know I'm not going to get paid for that is valid care delivered. And so then where am I going to be? And so it's just purely a cost of doing business for us. There's no mechanism for us to bill or collect any additional revenue for this process.
Representative Ward.
Thank you, Mr. Chairman. Mr. Helling? I said that right?
Dr. Helling, yes.
Thanks, Dr. Helling, sorry. Thanks for being here. Have you considered concierge care? Because there's a movement across America, because insurance companies are treating folks this way, of doing care where the payer is the patient. They pay either a fee, or you just tell them up front, it's going to cost this much, I'll do the procedure, you're responsible for paying it. I would like to see the industry move in that direction, since there seems to be so much corruption, and I'm wondering your feelings about that.
Go ahead, Doctor.
Mr. Chairman, Representative, there are some physicians who have taken that practice model. They're just not going to deal with insurance payers. Unfortunately, for surgery, it's not just me. There's a hospital fee, there's an anesthesiologist fee, there's some other ancillary, which make it difficult to set up that model. But certain specialties, that is the way it's done. The issue, though, almost everybody has health insurance, and they pay good money for their health insurance, and they should expect to be able to get certain services from their insurance. And so I think there's some hesitation to pay money in addition to what they've already spent on insurance when they think they deserve those services, and they do deserve those services. But that's a good point.
Interestingly, this committee, Representative Ward, I don't know if there's anybody here who would remember, We had an entire presentation on that very care model from one of the group here in Wyoming that is doing that. We may have to consider doing that again. Go ahead.
Mr. Chairman, actually in Wyoming, it's called direct primary care. It's actually a carve out of the insurance code. So it's not considered insurance when we have these arrangements, but it's basically family type practice that is implemented in Wyoming. So it is in Wyoming. It's just particularly being used in the family practice, and there's several practices. And that bill came through this committee as a committee bill, I think in 2015.
I'm glad you remember. Some of the old timers remember. Okay, with that in mind, committee, let's go ahead and I want to get a break here at some point, but I would like to get a few more in the audience. Sir, if you can come up, just trade places. Thank you very much for coming. The roads were good. You got lucky.
Mr. Chairman,
Yeah, you're not home yet. If there's
Chairman?
anybody else in the audience,
just one more comment concerning
comment, go ahead.
public comment. There doesn't seem to be a button to testify anymore online. Did we close it off? Or maybe LSO knows? When you go to the site, there's no button to testify now.
go ahead, Katie.
Mr. Chairman, Representative Ward, the testify link comes down at 5:00 PM the night prior to the topic, and that has been an established interim rule for at least a couple of years now.
Okay, if there's anybody else who wants to come up and take a seat, well, this gentleman addresses us. Come up and have a seat. They're soft. Aren't they soft?
Okay.
They are. Go ahead, introduce yourself, sir.
Good morning,
Welcome.
Mr. Chairman, members of the committee. My name is Ross Schriftman. I'm a citizen of Casper, formerly from Pennsylvania. I've been a licensed insurance agent since 1975, and I served as the voluntary legislative chair of the Pennsylvania Association of Health Underwriters. I appreciate all the testimony. I've dealt with many of these issues as an insurance agent for my clients over the years. In March of 2020, Pennsylvania locked down basically our healthcare system. The governor had an order that insurance agencies would be closed and we couldn't assist our clients. That decision was changed almost immediately. And that is because insurance agents answer many of the clients' questions up front so that when they go to their medical provider, they have more information about what may take place and what may not take place. I want to address the pre-authorization situation from my experience, as well as related issues of denial of claims. About 20 years ago, one of the insurance companies decided that they would eliminate their pre-authorization program. It was costing them money besides the providers. Obviously, they have not done that. There's been a huge consolidation into a corporate model of the insurance market since the Patients Protection and Affordable Care Act, which I think is a misnomer. During that March period and for the year prior, I had Medicare clients. I do Medicare supplement. I don't do Medicare Advantage. I do long-term care and I do health insurance, or I used to do health insurance. The governor of Pennsylvania and his Secretary of Health, Dr. Levine, who's now on the federal level, decided what was essential and what was not essential. What was not essential was things like my clients that had back surgeries put off, a friend of mine who couldn't get his father's diagnostic test and he ended up with a brain tumor. I had that client with a back surgery have to travel to Florida to get treatment for her back. What was determined to be essential was abortion clinics. That was essential to kill babies. But my clients, my Medicare clients, couldn't get prescriptions because off-label prescriptions, the FDA actually censured doctors to provide that. So, you know, it's a difficult situation. But as far as assisting clients, That's what insurance agents do up front. And I've had discussions over the years with my clients, with their medical providers, with the insurance companies. The difficulty is, in the old days, I could call the vice president of marketing and say, get on the claims department, get this done. Now the vice president of marketing is some corporate lawyer somewhere. No offense to lawyers, but that is a huge problem. We don't have access like we used to have a relationship with the companies where they could call the claims department and say, we have a problem. My feeling about what might be a solution is, first of all, these companies are licensed, and they have to have the feeling that if they don't do the job they're supposed to do, they're going to lose their license and not be able to serve their business in a state. So that's one thing. The other thing is, these companies need to recognize that the ultimate client is the patient, not the regulators. It's the patient. I encourage every citizen to call you guys, to call the departments and complain when their insurance companies are not doing what they're supposed to do. And in the old days, you could fire your insurance company. Now they have too much control. We talked about PBMs, and I think that's the next session. There's a PBM, pharmacy benefit manager, that is also a pharmacy, a national chain, and also owns one of the major insurance companies. That's collusion. That shouldn't be. So I appreciate your time, and I know we're kind of before a break here, so I really appreciate the opportunity to speak to you this morning, and I'd be glad to answer any questions.
We appreciate you coming before the committee, sir. Any questions? I'm seeing blank stares. Apparently you're off the hook. No questions. Thank you very much for coming. Sure. Okay, go ahead. Heather, you can start first. And I will tell you, after we get through the three of you, we're going to take a break. Yeah, or somebody may have said if. Yeah, go ahead, Heather.
Good morning, members of the committee. My name again is Heather Roday, and I represent Blue Cross Blue Shield of Wyoming. Wanted to talk a little bit about our company just really quick. We have approximately 300 employees in 9 offices located only in the state of Wyoming, and all of our call centers are locally located here in Wyoming. We cover 125,000 Wyoming members plus 85,000 additional members through national agreements. These insured citizens depend on us to help make healthcare affordable through our insurance products, and we take that responsibility very seriously. Wyoming has some of the most expensive healthcare services in the country, and we're on the hook to pay for those services for our members. Our goal is to pay for claims for our members and not use prior authorization procedures to slow down treatment or deny reimbursement to providers. If the treatment was appropriate, the provider performed it, then we need to pay for it. So this morning, I offer a few perspectives about prior auth from our perspective. We require prior approval for procedures and prescriptions to promote safe, timely, and cost-effective treatment for our members. Since our members pay premiums and have cost sharing, it's imperative that we are good stewards of their money. We have medical policies approved by the Medical Policy Panel of the Blue Cross Blue Shield Association, representing all plan affiliates, with monthly meetings to stay current with policy management. Our local medical clinical experts provide refinements to national policy that accommodates Wyoming members. And this group includes an employed group of physicians, nurses, pharmacists, as well as management. So there are some good reasons to have prior authorization. So to protect scope of practice. In Wyoming, some dentists are billing for sleep apnea. Some Wyoming physical therapists are billing for nerve conduction studies when the standard of care is to have physicians perform these services. And some dermatologists bill insurance for cosmetic procedures, which are not medically necessary and not a covered benefit. Physician providers represent a wide variation of practice of evidence-based standards of care and early adoption of innovative treatments. These varied practices are best governed by the prior authorization approval. Some patients want to be transported long distance across the country for convenience rather than medical necessity, and prior authorization helps minimize these costs. Prior auths prevent members from being subjected to treatments considered to be investigational, experimental, or not effective. Expensive genetic tests are being ordered for many reasons, regardless of whether the results are impactful for a member's treatment. These drive up the cost of healthcare. Hundreds of prior auths come in for off-label diabetic injectable medications being requested for the inappropriate use of weight loss. There are 15 of them sitting in the queue this morning. These drugs cost more than $11,000 per year, and if no prior auths were in place, they would increase costs to the plan and all of our members. Prior auths provide assurance to providers that they will be paid for the treatment that they perform beforehand, rather than telling them afterward the treatment wasn't covered and therefore possibly refusing payment. Prior auths allow savings to members and business clients approving equally efficacious treatment with drugs which cost less. There are also valid reasons to deny prior authorization requests. The patient might not be a Blue Cross a member of our company. The plan that the patient is on might exclude the requested treatment from coverage as part of the benefit design. And prior auths protect members from having to pay for hundreds of thousands or millions of dollars for treatments which might not be a benefit covered by their insurance plan. Blue Cross Blue Shield of Wyoming has an ongoing corporate initiative to reduce the number of prior auths. Over the last 2 years, we have voluntarily reduced the number of procedures requiring prior auth by 28%. This was based on a review of approvals and in some cases where services were being authorized more than 80% of the time, therefore the prior auth requirement was removed. While we appreciate the challenges some providers find regarding prior authorizations, here are some examples of how items mentioned in the proposed bill that we haven't talked too much about might be discussed about for our local market. In 2022, we received 51% of prior authorization requests by fax and mail. The reason some of the prior auths take so long is because these requests must be identified, scanned, keyed into the system manually, which can take 4 to 7 days just for that. If all prior auths came in electronically, the response time could be improved. Only 27% of the prior auths last year came in an electronic form. Some providers are not adhering to definitions of what's standard and what's urgent, which slows down the response time, especially for truly urgent requests. Providers sent in prior auths designated as urgent, meaning life and limb threatening, 64% of the time last year. Once our clinicians reviewed the documentation to determine life and limb threatening requests, the true number of requests falling into this category was about 2%. Those that are found not to satisfy urgent requirements are reset to the standard timelines, which also delays the response. Additionally, 96% of dermatologist requests were initially submitted as urgent, and rarely do they satisfy the urgent requirements. 42% of orthopedic requests were initially labeled urgent, and not one of them satisfied the urgent criteria. Prior authorizations often don't come in with complete information. We do not allow non-clinicians to deny prior authorization requests for lack of information, so our clinicians must review each request manually and will often have to deny for medical necessity because of lack of information. If more complete information were submitted at the beginning of the PAs, this could be processed faster. Some requests also take a long time to research, much longer than 48 hours, sometimes longer. So the suggested bill that we're happy to talk about offline with the bill sponsors, but some of the concerns that we have include requiring statistics by physician specialty will require all providers to submit additional data than they currently do. This would put even more requirements on the provider. Requiring prior authorizations to be reviewed by a clinician with the same specialty and time experience requirements will remove the ability for us to implement practices to actually automate the process. While we currently only have clinician review, we are implementing technology to automate the process and speed it up. For example, for a gastric bypass surgery, if the patient had a BMI of 35 or less, it would just be automatically denied. The requirement found in this bill would remove the ability when we are actually trying to work to speed things up. If services are required to be discussed with a physician before they are denied, timelines will increase dramatically as providers are difficult to reach while they are seeing patients. We heard the doctor talk about that earlier. This will provide an additional burden on providers, and I guess our question is, would providers want faster responses or more calls before denials? We can talk about that later. The requirement to have actively practicing state licensed physicians in the same specialty with experience for 5 years for the external review is problematic. We use 2 external review organizations, neither of which require physicians to have an active license in Wyoming. With a shortage of providers in Wyoming, this could be problematic as it would slow the process down. We are not denying initial treatment for opioid addiction care, but we do find the need to watch cases in residential care to ensure that the member is still participating in the treatment or is enrolled in the proper level of treatment to confirm that we are not paying for inappropriate services. The duration of time allowed for a prior auth in our company varies. Some are very short for hospital stays and some are very long, over a year. They provide natural checkpoints to monitor care and adjust as necessary over a course of treatment. Prior auths for drugs are often tied to FDA dosing requirements, and if dosing exceeds these requirements, it can lead to off-label or clinical testing uses, which are not covered by the plan. So while I've stated many reasons why we have prior auths, wanted to share with you all that Blue Cross Blue Shield of Wyoming is willing to have discussions with the bill sponsors to work out language that we believe could be achievable to actually make things better. We understand that there are ways that we can work together to improve the processes that you have heard about thus far this morning. However, it is important to note that whatever language is placed into bill drafts is applied consistently across all payers. We've talked a little bit about that this morning, over which the state of Wyoming has jurisdiction. Part of the reason why we're having this discussion is that payers have the different rules, which is frustrating for providers. We understand that, but any legislation which carves out payers from following consistent rules doesn't solve the concerns presented today. It would only continue the non-standard approach we see. So we look forward to further discussions to help develop a Wyoming-specific language that eases prior auth processes while keeping them in place to help control the high costs of care received in Wyoming. Thank you.
Thank you. Let's go ahead and go through all 3 and then we'll ask questions. Yourself, sir.
Good morning, Mr. Chairman, members of the committee. My name is Bruce Spencer. I am an attorney licensed to practice here in Wyoming. I represent the Mountain Health Co-op, which is a small health insurance company that insures people in Montana, Wyoming, and Idaho. Our primary members are members buying on the individual market. This is not group health insurance paid for by an employer, but rather an individual who's gone out and purchased this policy themselves. And we have close to 20,000 Wyomingites as part of our members right now. I want to give you some figures that I got from my folks before I came up here, because I thought, frankly, you'd be interested. And I found them incredibly interesting on prior authorization. Okay, so for medical prior authorization in Wyoming last year, we had 306. Drugs, it was 894. Now, put that into perspective and context. There's 20,000 people that are insured, and you're going to, of course, multiply by many times the amount of procedures or drugs that those 20,000 people get, and only 306 on the medical side and 894 were subject to prior authorization by the Mountain Health Co-op. However, that small amount of prior authorization saved the members of the Mountain Health Co-op $4 million plus in Wyoming only. So this is a very important issue. And of course, there are 2 sides, and you're hearing the other side now. Like the previous speaker, the Mountain Health Co-op absolutely agrees that we should have good and productive discussions with providers and to come to you folks with some agreed language that we can all work with on prior authorization. We agree. We think that something needs to be done. We are listening to those providers and we hear those concerns, and we think we can get together as adults and try to work out some suggested language for you folks. That is the way this process should work, by the way. Turnaround time. The standard turnaround time for a Mountain Health Co-op in a non-emergent circumstance, a non-emergency circumstance, is 5.32 days. I will tell you, I've looked at a lot of states, and a lot of states say 7 business days, 14 business days. So we're under that standard in other states. And that, of course, is something we can certainly discuss with the providers on a bill we might present to you. But 5.32 days isn't bad. In expedited, okay, it's an emergency situation, 5.4 hours, 5.04 hours. So we're trying to move these things through as fast as we can, given the circumstances. In terms of transparency, I'm informed that our third-party administrator does post the procedures that are subject to prior auth and the requirements on its website somewhere. I asked about look back because we heard testimony this morning about a 10-year look back. Mountain Health Co-op was 1 year. Okay, the reason I'm bringing these things up is that you hear statements, and I'm not saying they're not true statements, but I'm asking you to please not apply those blanketly to the entire industry. Mountain Health Co-op doesn't do those practices. So I just think that that's important. So why is it that we're asking for prior auth, okay, other than money, right? Well, it is so that you have a second look sometimes at potentially dangerous medications, procedures that aren't necessary. That's why we're asking on certain procedures, okay, and remember, it was 306, to have a second look, because we want to step in there. Here's the sad fact. Okay, studies show that as much as 20 to 30% of care provided as defensive medicine by physicians, because physicians are trying to avoid potential litigation for failure to diagnose, which is one of the major malpractice claims they face. Okay, and so they look at their sheet and they say, we've got to check off all these boxes so we don't get accused of failure to diagnose. Well, let me give you an example. Let's say I have a member that's gone in a couple of months ago and they get an MRI because they're having a problem. And then they go to a different physician to get a second opinion. Absolutely nothing wrong with that. I would encourage people to do that. I think it's good practice. It's good to have different opinions from different doctors. But that second doctor looks at the sheet and says, oh, we need to order an MRI. Now that procedure is probably under prior authorization. And when they call, we're going to tell them, do you know your patient had an MRI 2 months ago? Is there some legitimate medical reason why that MRI 2 months ago isn't good enough now? Okay, and they say, no, there's no reason we need one now. We didn't know that. You've now saved a lot of money for that member's plan. Okay, it's a legitimate tool to be used. Does it need sideboards? Sure. I'm perfectly willing to discuss sideboards, as I believe are all of my colleagues. Again, this is a tool used to protect patients from unnecessary exposure to risk. I think we heard Senator Bouchard give the story of being suggestion of double dose and moving into intensive care. Okay, but a lot of patients aren't in the position or are not comfortable with pushing back against their physician and saying, yeah, I'm not so sure that, what are the risks of that procedure again? Is that the most safe way to do this? Are there other avenues to do this that don't involve maybe a risky procedure? That's what prior authorization does. That's what the step therapy they were talking about does. It says, wait a minute, have you gone through these non-invasive options first before suggesting this surgical procedure? Or what about some other procedure rather than this one, which contains a higher risk? So believe it or not, that insurance company for their member can kind of step in and help protect them a little bit. I'm not saying that providers in Wyoming aren't providing medically good care. That would be incorrect. It's simply not true. I know they do their best. But all of us do our best. Sometimes you get blinders on and believe this is really the only way to do it, and there might be alternatives. It leads me to my last point. It is almost impossible for physicians to keep up with the pace of medical knowledge today. They are extremely busy people. They are extremely bright people, but they only have so much time to do medical research to keep up. So this little fact really struck me. In 1950, it took 50 years to double the medical knowledge. Okay? In 2010, that was 3.5 years to double medical knowledge. 2020, 73 days. It's from a study posted on the National Institutes of Health. Prior authorization can have teams of people whose only job it is to keep up with the latest medical information. So it is a service. It does provide a service. We were able to say, hey, you know, provider, did you think about this? It's kind of a newer procedure and it might avoid what you're asking. Can we look at this, please? I understand there's a necessary tension between a provider and the insurance company when the provider has given their best professional opinion. And I believe they believe it's their best professional opinion. We view prior authorization as an opportunity to assist that provider in providing better medical care to that member. And that's why we believe it's necessary. That being said, absolutely we're willing to sit down and have a discussion about what a Wyoming prior authorization bill should look like. I think we can come to agreement based on the tone and tenor of the testimony here today. I have no doubt in my mind that we can all sit around a table and come to an agreement. Thank you.
Thank you. Mr. Moser, ball's in your court, sir.
Mr. Chairman, members of the committee, Mike Mosier, Cigna, I will be thankfully brief because I cannot parallel the testimony we've heard over the last 2 hours. However, I will address the process since I've worked these issues for a couple decades. First of all, I think one thing that hadn't been mentioned is nobody was blindsided by this. We were approached by our friends and colleagues with the Medical Society, the Hospital Association during session and said, we want this as an interim topic. What do you think? And we said, absolutely. I think it needs to be addressed. So there's no us and them in this process. It's us trying to work out a solution. We understand that it needs addressed. One thing, and we've worked at the table, same table for a lot of years. So there's no tension. I know there's disagreement. That's part of the process. But I think everybody wants to reach a solution on these issues. I don't think you've heard anyone who said we didn't need to address this issue. However, I think it's important that we come together and look at that. I'm fond of saying that I am not nearly the smartest person in the world, but I know people who are. And I want those smartest people to look how other states are done. They're in a process like this, coming together as a group, as we've done in the past. You need to figure out what to address, which we do. What can we do about it? What's federal, what's state, what specifically Wyoming? We want specific Wyoming solutions and how to do it. And I think we have parties at the table that are willing to reach that point. Obviously, there are some issues like standardization that's of interest to everyone. And so members of the committee, Mr. Chairman, I'm not going to be redundant with anybody else. However, having done this a whole bunch of times, I see on this issue in particular, everybody at the table wants to reach a solution, but we're going to need some time to digest, to throw out different ideas, and to continue to listen to this in the process. And I believe we can get you a fine solution that will have everybody on board. And thank you. I'll take any questions.
Thank you, Mr. Moser. Quick question. Is it, who are you representing? Are you representing
I said
yourself?
Cigna.
Cigna? Okay,
Yeah,
very good.
not the liquor dealers.
Okay, committee, you got three people to ask questions of here. And then we're going to take a break. So let's make them good pointed questions, good questions, polite questions, et cetera, and then we'll take a break. Senator Bouchard, go ahead.
Thank you, Mr. Chairman. So this question is for all three of you. I looked through the legislation, or the proposal, but what I'm more concerned with is something to fast track and something that's black and white. So the gold card standard, which we see other states have, that's been I think one of the main things pushed in other states, that if a doctor has a 90% approval rate, that they have a gold card standard, meaning that they don't have to go through a harder process. I think that's a great way to do it because there's a track record there. I'm sympathetic to some doctors, as you mentioned, there's doctors that do things wrong. And I think that the gold card standard is kind of a way to get around that or to fix the problem. So I'd like to know from all three of you what your opinion is on the gold card standard.
Go ahead, sir.
Oh, you got to press that.
That's a tough
Mr.
part of
It is.
testifying here is getting that button.
It is, Senator. Mr. Chairman, Senator, we have concerns with the gold carding process. Studies have shown that after a provider is gold carded, that they then don't stay to the strict standards that got them to a 90% approval level. And so it winds up costing more money in the long run. It is a process adopted in other states that has caused great problems. Texas would be a prime example. It has not gone smoothly in Texas. There is a huge backlog and the departments had to hire a lot of people in order to manage the gold carding program. And at this point, we don't feel it would be appropriate in Wyoming.
Okay, further questions, committee? Representative? Who wants to go? Go ahead first.
Mr. Chairman, that was for all three panel members, that question, same question.
Does anybody else want to answer that? Go ahead, Ms. Roday.
Mr. Chairman, Senator Bouchard, we have done gold carding in the past and have discovered that some of the providers ended up trying to get procedures through that would not have been approved according to that gold card. I mean, we can still talk about it, but I think that we also have some concerns.
And Mr. Chairman, briefly, nothing's off topic. I understand the concerns of that, especially in Texas. I've seen that, but that being said, when you come to the table with a group of people, everything's on the table. So I can't really say heck no to anything until we all get together and start discussing.
Okay, now we're going to start at this end of the table and work our way down. Who had their hand up down there? Representative Penn.
Thank you, Mr. Chairman. So as a provider, I hate prior authorization, so you haven't heard much from me yet. However, I do also, as a lover of liberty and, you know, a person who wants to be conscious of what healthcare costs, which is astronomical, I do recognize the need for those guidelines to make sure that we aren't frivolously spending money. So if you each three could also answer a few things that I thought might be reasonable to include in legislation. Do you require, or do you have some sort of standardized form, or does Wyoming have a standardized form? Do you each have your own individual form? Do you have a process set up by which providers can submit the information electronically currently? With the gold card standard, I see it as maybe a plus. There was mention that people, you know, as part of the issue with prior authorizations as far as denials is that there is a lot of incomplete prior authorizations. As a person who would be involved in those types of things, if I knew that I had the potential to get some sort of a gold card standard, I might spend more time making sure that I did a good job to get that thing authorized the first time, because we are up against situations where, like, we just need to get this done fast. And when you get this prior authorization, you know, you roll your eyes and you think, okay, whatever, just throw some. I tell my medical assistant, try this and this, you know, hurry and look through the patient's medical record. Let's see if we can throw some, but I don't necessarily spend as much time as maybe I could. But if I knew that this might end up ultimately making the process easier for me and my staff, then that might be something that I would be more interested in. Also, what if we added something like so once you achieve gold card achieve that standard, it doesn't automatically, the monitoring would continue, in my opinion. It continues, so you could lose your gold card standard if you don't continue to operate in a reasonable fashion. If you could just start with those first things.
Okay, go ahead. You have a handful there. Go ahead.
Mr. Chairman, Representative, just those. Let me start with gold carding first. Mr. Mosier correctly said it is something we certainly can discuss. It is incredibly complex, gold carding is, and so I don't know that I can really address all of your concerns in this meeting. The suggestions you've made, I have seen in gold carding bills. So, I mean, there is language that addresses them, and sometimes physicians don't like it, and sometimes plans don't like it. So I get that. In terms of electronic submission, my folks are working towards that. They aren't quite there yet. I don't know that all the providers are there yet either, right? I don't know that we're all on the same page yet. I can tell you it is absolutely a goal to make the prior authorization process easier and faster for everybody involved. And so there is no question that we will do that. Is it wise to legislate it? I'm not sure, because of the way technology evolves today, right? I mean, things just change so fast, or a new method could come up. And we all need to move forward, right? We're still using faxes, you know? It's kind of ridiculous that in the medical context, faxes are still being used. As a lawyer, I discovered encrypted email quite some time ago. I think your other question.
Standard form.
Standard form. I think that's a really good question. I am not aware of any legislation that mandates that all insurance companies must use the same prior authorization standards. But maybe there's a form of submission that could sort of be the same, somewhat like when you submit a claim, you're using a standard form. We certainly can talk about it. I don't know if there's a solution out there for that, but there might be.
Mr. Chairman, Representative Penn. So we do process our prior auths electronically. We have a vendor that is being careful about proper names. We have a vendor that works with many other national insurers that so that the provider can go into this particular vendor and see all the different kinds of the different plans that accept it. So that is a standardization within a vendor. What we also have included within our electronic prior auth process is a electronic benefits check ahead of time, so that what we're trying to do is make sure that not only is the service prior auth ahead of time, but also the benefit to ensure that it is covered, because that's kind of a two-step process. We've installed that to make it easier and improve the approval rate. And I think we've said we can talk about gold carding, and certainly I appreciate your input. We'll take that back to our provider folks, that perhaps if it were a place, it might make the completeness of applications a little bit easier. So thank you.
Mr. Chairman, Representative Penn, to just button up to my colleagues' testimony, electronic submissions, that's a natural process. I think it's occurring. Now, bear in mind with Cigna, a large bulk of our business is through the EGI, and there is an individual back there that would know a lot more about that. And it is standardized because you have one system. So I think whether it needs codified or not, as Mr. Spencer mentioned, I don't know, because technology is evolving so fast. I know one of the interesting things, as you alluded to, is when you mentioned that any part of today's society is still faxing, you get an eye roll. So I think technology and ease and speed is making that process happen. The question is what needs specifically addressed, or whether it's happening on its own. Thank you.
Okay, we're going to keep coming down the road there. It looks like you're next, Representative Warnock.
Thank you, Mr. Chairman. Was anything changed to the prior authorization process during COVID? And what were those changes? And then have things reverted? What has happened since?
I think Mr. Moser should have to start that one.
Mr. Moser, okay, Mr. Moser can start.
Mr. Chairman, Representative Warnock, I'm not sure if anything changed. Certainly, the way healthcare was being administered changed. I think that was the big difference, is because of the restrictions and the requirements. But I'm not sure if anything regarding prior authorization changed.
So, Mr. Chairman, Representative, yes, the Mountain Health Co-op and I believe other insurers voluntarily suspended certain prior auth of certain procedures during the COVID emergency. That has gone away. I think for the Mountain Health Co-op, it was June of last year that they went back to the standard prior authorizations, but some of that was lifted during COVID voluntarily. It was not mandated, but insurers decided they wanted to try and help, and that was a part of the process. That's about all I know about it, but I know it was lifted temporarily.
And for Blue Cross Blue Shield, I know that the volume of services went way down that were being requested. And so in terms of the prior auth procedures, I'm not aware of any changes.
Very good. Representative Clausen, do you still have a question?
Thank you. You know, I think we all see prior authorization as an important tool to save money for companies, which means to the consumers, and it can offer some better medical care. I think what we're hearing from the providers is right now it's not efficient, it's too burdensome, it's not standardized. One of the, I guess, benefits of being the only state not to pass a prior auth law is all of you have the abilities to go back to your national organizations and say, what works well? What can we bring to Wyoming that's going to help Wyoming? And, you know, and we can ask the same thing of the medical and the hospital associations. So I guess that would be just more of my ask to all of you, is that you reach out to your organizations and find nationally what's working and what good parts can we take and what's not working that we can avoid. So I guess my question on that is, I'm just going to ask if all of you would be willing to do that.
Speaking on behalf of everybody, yes. And we need to address the rural nature of our state and all the eccentricities that come with living in this wonderful Wyoming.
Well spoken. Okay, we're moving down the row. And Representative Yin.
Yeah, Mr. Chairman, thank you. You know, I guess it's more, it's on that same line of what do next steps look like? Would you, as well as our provider friends, be willing to sit down and bring us a bill draft to our next meeting? What do you see as where we go from here? And you know, certainly those in the group can disagree on what that bill draft could look like and be willing to bring us amendments to whatever bill draft comes as well.
Mr. Chairman and Representative Yin, that would be my idea. We'd have a couple meetings in person. I think everybody's expressed interest in working together on something, and everybody wants a solution. And so I think the key would be coming to you with agreed to language. Now, if there's any differences or anybody wants any more, we can certainly discuss that. But I'd rather have a common body of agreement and work from that because it's much easier. And that's also, I mean, just taking another state and plugging and playing in Wyoming, or a national model and plugging and playing. The good thing about having everybody at the table is we do things differently here because of the nature of our state and for other reasons. And so that way we could bring you something that fits within our system instead of tailor fitting somebody else's stuff to fit us, if that makes any sense.
Mr. Chairman, we'd be willing to do that.
Okay. Representative Ward.
Thank you, Mr. Chairman. I want to thank Mr. Bruce Spencer for your testimony and your numbers. And I wanted to suggest that 5 hours for emergency prior authorization, 5.32 days for prior authorization turnaround, and a 1-year look back seem more than reasonable. And wanted to ask the other two representatives if that would be doable, because I think that's a great place to start.
If I could just, Mr. Chair, that's what my company does, but I will tell you, there are standards set in other states, and I think those are really the timelines we ought to start with and discuss. because it's not a one-size-fits-all situation. My folks can meet those standards. So if the numbers in a proposed bill are large enough that everyone can meet it, that's acceptable. It's where you get down to very, very small numbers in very, very short time. The reality is it can't be done, but I'll let the others speak.
Mr. Chairman, Representative Ward, I think those numbers would be difficult for us to hit. But certainly, I've been told that we can move in a more expedient direction. At this point in time, I don't have any solid numbers about what that actually looks like, but we can certainly work to improve timelines.
Mr. Chairman, Representative Ward, to avoid bravely going where no lobbyist would go before, I cannot guarantee that but I will say that standardization is a big step in that direction, which is, I think, is one thing we'd be looking at. I think with the EGI, there is a pretty fast response time, but we need to look at how that's done, how different plans work, but that certainly would be up for discussion.
Some
It
follow-up.
just looked like the Star Trek module here with him giving that quote. Okay, any follow-ups?
Thank you, Mr.
Go ahead.
Chairman. This question is to all three. Have you issued a prior authorization and then not paid? That's part one. And part two is, do you require a prior authorization again after it's already been approved? If so, how much time elapsed?
I can go first. I have no idea, honestly. Mr. Chairman, Representative Ward, I would need to dig into that, so I'm not sure.
So, Mr. Chairman, Representative, I am not aware that Mountain Health Co-op has approved a procedure and then not paid. I believe Wyoming has a prompt to pay statute, which indicates that after a certain amount of time, I believe it's 30 days after a claim is submitted, it should be paid absent different circumstances. So Wyoming has a law that covers that. In terms of the look back, I was looking at some comments that I got on the proposed bill. Here, let's got the right sheet. I think that what happens sometimes is you'll get a prior authorization for 3 or 4 months, and then they say, well, we'd like to look at it again. And the question is, well, is the treatment being effective? Is it effective? Because if we just give you a blanket prior auth for years and the treatment's not effective, that's not assisting the member. And so they do want to look at it again. That is also something that we certainly can discuss with the providers when we sit down to work on this bill. That is there an appropriate length of time for, say, a chronic illness where prior authorization would be applied without having to come back? And there might be an appropriate length of time. I think there's going to be some pushback between us, right? The providers might want a very long length of time, whereas my clients have given me some information that said, look, we need to look at it, the effectiveness of drugs change, or there's new drugs that are out on the market. And so, yes, we'd like to be able to look at that every 3 or 6 months, or whatever the appropriate time frame is. So in answer to that question, yeah, there is a limited time for prior authorization. It's not unending, but there are legitimate reasons why insurance companies feel that it shouldn't be unending.
Anything to add, Heather? You grabbed that mic with some uncertainty.
I think that, so sometimes what will happen in the prior auth process is a set of services might be approved, and then we might get some information that says that what was approved was actually not performed. And so sometimes those have to go back for further discussions about what happened, why, what did that happen. So in some cases, initial prior auths look different, and so there might be some payment issues on the back end if things were different. And I think that, I don't know how far back we go back and look. I've asked that question while we were sitting in the back of the room and couldn't get an answer.
Follow-up, go ahead.
Thank you, Mr. Chairman. During the last few years, I was prescribed ivermectin by my doctor, went to my pharmacy to fill it, and they told me that my insurance company would not cover it. So my question is, during the last 3 years, and this is to all of you, have you denied prescriptions for ivermectin or hydroxychloroquine, which are inexpensive, well-studied, and have an excellent safety profile? If you have, please tell me why. Thank you.
Go ahead.
Mr. Chairman, Representative Ward, I don't know. I do know that we require a prior auth for ivermectin. I have been told that, but I don't know the specifics of any particular member cases. They don't ever share that with me.
Mr. Chair, Representative, I am not aware of any issues regarding those two drugs. It's never come up to my level. So that would lead me to believe that there's not a systemic problem with either of those two drugs. I don't know whether they're covered or not. They may very well not be covered. I just don't know, but I know that it hasn't reached my level.
And Mr. Chairman, Representative Board, I too have no real idea. I'm a humble country lobbyist, not a lawyer or a pharmacist, but the EGI might be able to answer that better since they are Cigna as well. I'm not sure if there's any issues with that particular drug.
Okay, thank you very much. We're going to take a break now. It is now, if it's quick, because we got bladders ready to burst. Go ahead, Representative.
Thank you, Mr. Chairman. So, you mentioned a prompt pay statute. Could you give me citation for that? You said maybe 30 days or something. And-
Mr. Chair, Representative, I'm happy to look it up. I don't have it memorized.
Okay, and then my question would also be for maybe Department of Health, is Medicaid included under that? Because I know there's a lot of Medicaid that does not get paid within 30 days.
Mr. Chair, Senator, or Representative, the prompt pay statute I'm referring to, I believe, is in the insurance code, so I don't believe Medicaid would be subject to it.
Okay. It's now 11:12.
I just have one.
Oh, one more, okay.
I have one.
It's coming off your bathroom time. Go ahead.
Thank you, Mr. Chair. So I just have a quick question because earlier you stated that pre-authorization is to help the doctors in doing their job. So can you tell me what kind of training your customer services reps have to know how to help the doctor do his job better? And for sidestepping, for instance, I have a chronic disease where I need shots in my back. However, that was a discussion between me and my doctor, and it took me 6 months of physical therapy to get those shots at the end of those 6 months, which then in turn took me at least 3 hours a day out of work because I had to go to the doctor, do the doctor, go back to work twice a week for 6 months, only to in turn, at the end, get the shots in my back after wasting 6 months of money to physical therapy. And what is the process of the training for your reps to recommend me physical therapy for 6 months when I've been getting shots in my backs for 6 years now?
Go ahead, Heather.
Mr. Chairman, Representative Trujillo, in our company, the folks who make those clinical decisions, clinically trained people, they're not the member service folks who take calls in the call center. And then regarding we have medical policies that are set, and those are the ones by which we abide and by which our clinicians abide by, and they're the ones that also reevaluate that as well.
And Mr. Chair, Representative, that would be the same for the Mountain Health Co-op as well. It's not a customer service representative making those decisions. And understand that they're following the medical policy procedure, and in most cases, that is deemed to be the best avenue of treatment and the best step therapy treatment. Unfortunately, in your case, it didn't work with physical therapy, and you can't guarantee that that sort of treatment or any sort of a step therapy is going to work in every case. The human body is much more complicated than that. And so that is not a standard that anyone can say is appropriate. Just like we could never look at a physician and say, you have to be right 100% of the time. I know they want to be right 100% of the time. They work very hard to do that, but no one can meet that standard. So it is clinically trained folks that make the decision. They are following policies and procedures that are reviewed quite often, in fact, and changed as necessary. But is that a guarantee that it's going to work in every circumstance? No, I'm afraid it's not.
Mr. Chairman, Representative Trio, it's pretty much the same across the board. We all use clinically trained people for that. It's not customer service, so.
Okay.
Follow up?
Follow up.
So when I'm calling for a pre-authorization, or my doctor's calling for a pre-authorization, and they get somebody from another country, so they're putting the data entry, your clinical people are reading numbers, facts, codes. How are they making this decision when a doctor and patient have already made a decision for their care? That's where I'm trying to get, because we're doing this, but we're not looking at the people. What are the odds of me knowing 25 people in my district that has suffered the same situation that I'm talking about? That's a lot of people.
Jump in.
Mr. Chairman, Representative Tria, I don't really know how to answer that. That's a niche that's not my specialty. I know how they're clinically trained, but as far as individual cases, I can't really address that.
And Mr. Chairman, Representative Trujillo, in our case, our folks are not in a different country. The folks who are making our decisions are here in the state. So they are the medically trained folks who are reviewing the cases and making those decisions.
Yeah, and for the Mountain Health Co-op, folks you would be speaking with would be in Salt Lake City, most likely, or Helena, Montana. The information is sent to somebody that's clinically trained and then follows the procedures that we discussed before. So that's who's making that response to you.
Okay. It's now 11:17. We will see you all back here at 11:30 to work this topic further. Are we live? We're live. Welcome back. Couple things to take care of before we move on here. Number one, if you came in on this side of the room, you missed a sign-in sheet. You got to make sure to sign in so we know you were here and who was here. So everybody please sign on your way out if nothing else. Number two, legislators, make sure you fill out your reimbursement sheet and get those turned in. Bring them to, just like that. That was a good demonstration, Senator Hutchins. Okay, so get those into us so you get paid and we'll move on. So we're gonna move on with this topic of prior authorization and hopefully bring it to a close here before we go to lunch. And then we'll talk more about it later this afternoon in our closing part, but let's bring anybody else public comment up to the table, please. Okay.
I think Marguerite's online and is going to testify.
Okay, do we have Marguerite online that wants to testify on prior auth? Go ahead and admit her in. And there she is, Ms. Herman. Welcome to Labor and Health. You're on the spot. Go ahead.
Thank you, committee and chairman, for this moment to testify. I've been listening all morning, and you certainly have been well informed of pros, cons, and complications. And I'm sitting before you as a member, as a National Association of Insurance Commissioners consumer rep, and I'm really drawing on some work done by other consumer reps, especially they made a presentation at the NAIC conference last month. And so drawing on their report, and which again is based on a lot of information and experiences and legislation in other states. With that, I will try to be brief. And I did not realize that Wyoming lacked this legislation and the only state to do so. So obviously this is right for legislative attention. I thank you for looking at it, making it an issue. The one thing that other states have done that seems to be a need in this process is improving access to care and continuity of care. And elements that seem to help the consumers and be cognizant of interest of all the parties involved is no prior authorization. And I'm just throwing these out as suggestions that have been found helpful to the process, and you'll have a lot to sort through. So I'm just adding to the sorting. No prior authorization for generic meds, no prior authorization for medication and treatment with low denial rates, low variation in utilization, or an evidence base to treat chronic illnesses. These been used to improve the continuity of care. Requiring prior authorization to be valid for the duration of treatment for at least 1 year. Require insurers to honor a patient's prior authorization from another insurer for at least 3 months, and that was addressed this morning as well. The second major thing is to promote transparency and fairness. Require reports on the impact of prior authorization on patient access to care, administrative burden, and system costs, which seems to address interests for a lot of the groups involved. Prohibit retrospective denials if care is pre-authorized. Require carrier to notify affected individuals about any new prior authorization requirement. The next thing, a general topic of things that you might consider as you write your legislation, if you decide to write it. Improve timely access to care and administrative efficiency. Establish 24-hour response time for urgent care. Require insurers to adopt software to facilitate automated electronic processing of prior authorization, and that the Department of Insurance implement standardized forms. Another thing, and then it included, also one thing that some states are doing is moving to ban prior authorization for certain behavioral health, something to consider. Recommendations for regulators that was included in their report. Monitor that would be for regulators for our Department of Insurance. To monitor implementation and compliance with federal interoperability rule, which had to do with patient access to their health information. Utilize existing authority to monitor carrier conduct. Support efforts to improve access and continuity of care, including reduced wait times, which you've already had presented today. Increase public transparency around utilization management, including details of initial and final denials. And again, this is a transparency issue, so everyone understands the process completely. Require use of standard forms and electronic processing, and require standardization in documentation and publication of medical necessity criteria. The other thing they mentioned is some states use this gold card laws, which you've discussed already adequately this morning. I'll just put it back on the table. And I'll say that sometimes the legislature, I've been watching the process for about 40 years. Sometimes the legislature is tempted to focus exclusively on one interest or another, when obviously it's become abundant today as you have several interests at the table that may seem competing at times, but we're all interested, consumers, providers, insurers, as making the process as efficient as possible, as to avoid waste as much as possible. And I think we're all aware of the high cost of healthcare in Wyoming, which drives up premiums. It makes insurance extremely expensive. So anything that does lower it is worth a look. But I would say abundantly clear also is you have a lot of interest involved, and it's important to consider the big picture. And I think you will. It sounds like you have a lot of information to put into that picture. And we've heard plenty about what's not working with the current process. And so I'm confident that, especially with Mr. Mosier's recommendation that everybody work together to a common goal, I think it can be reached. I encourage you to tackle this and to see what you can accomplish and get ready for the next legislative session. And with that, I'll just leave it and be available for questions. And if there's anything the consumer representatives for the NAIC can do, please let me know. They have access to a lot of information that may be helpful from the consumer's point of view, but all cognizant of the others, but from the consumer point of view.
Thank you, Ms. Herman. Questions for Ms. Herman, committee? Senator Barlow.
Thank you, Mr. Chairman. Ms. Herman, would you provide that NAIC report or the document to our LSO staff so it can be shared with the rest of the committee? Thank you.
Yes, thank you.
Anything else, committee? See nothing. Thank you very much for visiting with us today, Ms. Herman. We appreciate seeing you here. Anyone else online or in the room wishes to address this topic of prior authorization? See none, we're going to close the public testimony on that. Now we have a couple of options here. And I think rather than open up the next, I'll just call it a can of worms, the next topic, white bagging, I think we're going to go ahead and just talk about this topic real quickly, prior authorization, or what our wishes are. We'll probably do lunch and then we'll come back and move into white bagging. Or there's a lot of different color bags from what I heard this morning. White bag and brown bag and clear bag. And anyway, that being said, committee, we have a couple of options here. Well, we have more than two, but one of those is we have a draft bill or a model legislation that we could take, have it put into LSO format and work that next meeting. That's one possibility. Second possibility, and I will tell you, it's probably my preferred, but this is up to the committee, is that we take that group, as some have suggested, the group of stakeholders, apply a couple of legislators to that process and have them get together and meet and come with a workable solution. They're not going to come up with something that everybody agrees with. That never happens. Anybody that's been here long enough knows better than that. But come up with a workable solution, a workable bill in LSO format that we can then bring back for the next meeting and work. Now, we're going to limit the number of legislators. I don't want 8 legislators. I don't want 10 legislators. I would prefer having 1 or 2 and get a group of stakeholders. If everybody can agree to that, that would be my proposal. The third proposal is always on the table for us, is that we punt and say, let's do nothing. And I don't think that's an option at this point. I think that we have something that needs taken care of. So committee, comments, suggestions, jump in. Senator Dockstader.
Thank you, Mr. Chairman. Don't want to punt. Find a couple of well-qualified people and get the bill together so we can start to work it.
Further commitments or Suggestions, comments, and Representative Ward?
Thank you. Thank you, Mr. Chairman. My preference would be to discuss here the kind of things you want to see in that bill, all of us, and then have LSO draft from our comments.
Senator Hutchings, very good. I saw your hand. That was good.
Mr. Chair, appreciate it. I too agree with Representative Ward. Let's work on this and get something that we think would be a little acceptable with what we have from the draft bill. It's kind of a difficult thing to put together when it's not in our format. The talking, we've seen that in other areas when you get together with the quote unquote stakeholders. We're working with the PBM issue. And as far as I know, that's been since 2015. We're still getting stakeholders together. We're still talking and we're not getting anything done. So I say, let's get something sent to LSO to get drafted as soon as we can. Thank you.
Further comments, suggestions, committee? Representative Ward, or excuse me, Penn. I'm so confused today. Go ahead, Representative Penn.
Thank you, Mr. Chairman. So I might say let's maybe do a little bit of a combo of both. Like the Senator said, let's try to get something put out today. I have a list of things that I've kind of looked at and pulled from some of these various states' legislation that I think that might be applicable. If we could just make some suggestions, give them to LSO, similar to what we did with the bill ideas yesterday, and kind of get the ball rolling that way.
Further comments, suggestions, committee? Jump in. Do we have any motions, perhaps? Senator Dockstader.
Yeah, Mr. Chairman, not opposed to taking the time today if we need to. There's certain qualified people here that could do it. Penn is one, she's in healthcare. The two co-chairs maybe, let's get it roughed out, but let's not take a lot of time beyond what we've scheduled, so.
Okay. Are you making that as a motion?
So move.
I second.
Committee agrees. We got a first, second. Everybody in agreement? Everybody understand that proposal? Go ahead and restate it for us if you would.
Yeah, sure.
Senator Dockstader.
So we rough out the initial stages of it, perhaps Representative Penn, maybe one or two of the co-chairs, those who work in healthcare, and rough out the first stages of it and then send them out, get it done and drawn up and ready to approve at the next meeting or disapprove. But obviously we need to get something done here, so I'm saying approve.
Senator Barlow.
Thank you, Mr. Chairman. So I guess where are the stakeholders involved in this? Just at the next meeting with whatever draft legislation? So I actually oppose that strongly, and having worked on the Labor Committee this is my 9th year on the Labor Committee. Most of the big legislation that have come through the legislature, direct primary care, healthcare sharing ministries, et cetera, was done as a cooperative between stakeholders and interested committee members. And so I have no problem with starting off with a list of these are things we want to try to address. But then I think it's a smaller group of legislators. And part of the reason to have a legislator or legislators involved is to keep a fire under them so that there is a bill draft ready for you to review a month in advance of your next meeting and come back with your suggestions or et cetera. So I think there's a hybrid to be in there, but I think that the stakeholders will be better served having the stakeholders involved in this initial process than not.
Mr. Chairman.
Personally, thank you, Mr.
I think
Chairman.
a little closer than the good past chair realizes. We're closer than that. I think he's opposing something that's not there to oppose. Let's get this thing started.
Okay. Comments? Go ahead, Mr. Co-Chair.
Well, so we have the AMA model in front of us. The question is, do you want to start with that? Or do you want to throw out a list of suggestions for LSO to kind of go in their own endeavor and draft something differently? Or do you want to have a separate subcommittee task force where we could bring everybody together? I think that's probably the best for the next meeting, and see if we can get something in a draft form in LSO standards that has some input. I mean, I guess however we do it, I probably do think we should have a legislator or two on there. And so I know I'm in Laramie County where most of the stakeholders are as well. So I would certainly volunteer. We could also go up to Representative Penn's district, and we'd all love to get to Lander and maybe put a couple of us, 2 or 3 of us on it, have a one-day working group with 3 or 4 legislators, go through the Model Act, go through what fits for Wyoming. That might be the best to get something to our next meeting that we could at least discuss, that we feel comfortable as a starting point.
An alternative or something that fits in with what the co-chair just said is that indeed we could get that group together, realizing that they need to get together in the next 2 to 3 weeks. Put something together, get those lists, get that model legislation, and actually put something in LSO format. We can then email that out to all the committee members. And if we can get an email commitment or email saying, yeah, that's something we can work with, something we can move ahead and we'll talk about, then we'd have something in LSO format, an actual bill draft that we can work that bill. And that's the problem, is if we get too long, then we're not gonna have something to work. But that way, if in the next month, that group can put something together in LSO format in a bill, we can put that out to all committee members, approve it, get it to LSO, and get it an LSO draft, so we have a draft to work next committee. Is that reasonable, or anybody agree or disagree? Representative Ward.
Yeah, as long as we can just here today, let's come up with a list of things we want to see in that bill.
Let's do that. So first of all, let's commit a couple of legislators to work with that group. And and you all can say, heck no, Chairman Baldwin, I don't want to do it. But I would like to see Representative Penn with that group. Obviously has a key stake in this and has knowledge about it. And for pure passion for the topic and who wants to do it, I would suggest Senator Dockstader. If you two would agree to that. So one of you two needs to make a list here. Get your piece of paper out. We're going to throw you some ideas. She does. Okay. Is there anything that anybody is very passionate about? Let's go ahead and read your list to us. What do you have on there, Representative Penn?
Thank you, Mr. Chairman. So it seemed like a common thread among the various states that were identified by LSO said that we have a standardized form so that providers understand what the form is going to look like. They know ahead of time what type of information they're going to be providing. So a standardized form. Of course, that's easy to understand that the process is fairly clear and streamlined. The opportunity for this to be submitted electronically, and also that the instructions are done electronically, and appeals can be submitted electronically. The fourth thing on the list is a 24-hour return for prior authorizations for urgent requests. I have for chronic treatments, or so there was mention of chemotherapies and things where maybe people have switched, or they started with the treatment, but then they have to continue to get repeat prior authorizations for further treatments. There's one prior authorization request. I would like to see that if someone has to switch providers during the middle of a treatment course, that at least course can be finished out, or work on some sort of language that course can be finished out with the new provider before a second prior authorization has to occur. I would like to see some teeth in it with a fine. It was mentioned in one of these, a $5,000 fine for noncompliance. And then the last two that I liked the idea of, and it's listed in the Texas legislation, the first bullet point on the Texas legislation, which is kind of the gold card standard, and some of those things that we discussed about continually monitoring a provider so that they don't get too lax and start submitting things that really need more scrutiny. And then finally, on the hospitalization and prior requests, so it's the final bullet point under the Texas legislation. It says prior authorization request must be determined within 1 business day after receiving their request, or within 1 hour if the request is related to post-stabilization care or a life-threatening condition. So I don't know if others have questions or comments.
I would throw one suggestion, you can add it to that, is that I think we need a uniform definition of urgent and emergent, because it seems like that varies across all the payers. And they can bring their stuff to the table, we can get something more uniform, say what is emergent, what is urgent.
I think that the legislation that we had been given, if I remember right, I thought I saw a definition in that one that was submitted to us of urgent. But yes, I agree with that.
Good. Others? Go ahead, Senator Dockstader, or Mike, Representative Yin.
Thank you, Mr. Chairman. There's one thing that I heard, and it's on the list of, on 113 of our notebook. It's AMA's very last handout before we get to white bagging. It lists a new plan should honor the patient's prior authorization for at least 60 days. I think that's something that's worthwhile to consider, especially when we talk about the step therapy, to not make it so they're repeating step therapy or having to reauthorize when they're in the middle of a treatment regimen and then they go into a new plan. So I think that'd be worthwhile to consider within that subcommittee as well.
Absolutely.
Thank you. So the 24-month look back, I looked at 16 states that have look backs. They go from 6 months to 36 months. I'm not sure if that's a different law and a different motion, or if that could be included in this prior authorization. So I'd like the committee's thoughts.
Okay, you get chairman's thoughts first, since I have the mic. And that is, that probably needs to be a separate topic, separate bill, because I don't know that it's exclusively with this topic, and I don't know that it will fit together. So I think that is actually a separate piece of legislation, which we can propose to have drafted here in a few minutes. Senator Hutchings.
Maybe, if, Mr. Chairman, if the model that VA uses where we get a 6-month authorization, I don't know if that goes along with what Representative Yin was saying, to kind of, okay, you're going to get this much care for 6 months, and if you do need more, you need another authorization. Just see if that's something they would all be agreeable to, if you don't mind.
Other words recurring, Representative Ward.
Thank you, Mr. Chairman. I second Representative Clausen's motion or idea about the look back. I think there needs to be some limit on that, 6 months, a year, or something, because it seems rather unfair that that's able to happen. And I think that it should go in this bill. I'm okay with it being a separate bill, but I'd like us to address it.
Okay. Well, as soon as we get done with this first part, we'll deal with that one. Any other suggestions for this list? For Representative Penn, Senator Dockstader, and Barty. Yes, Mr. Co-Chair.
If there's a physician assistant instead of an actual, physician, that should still be counted as, without having make that an intricacy where there has to be an actual doctor. I think if it's a PA, perhaps a nurse practitioner, if we could add that in the mix of topics to talk about.
And I agree, that should be, as our other legislation we've talked about, calling it a medical care or medical provider. So it's inclusive of all those things. Okay. Excuse me? Yeah, the peer-to-peer. So, go ahead, Representative.
Thank you, Mr. Chairman. So fines were mentioned, looking into fines. I don't know that that's necessarily the best way to go. It's easy just to pay a fine sometimes. However, it seems like there should be a way to recoup cost of the hospital or the provider for going through this process, even if it's denied, actually. Because technically, if that cost can be recouped, I would wonder if generally the healthcare cost in general would come down, because then I'm not paying for my my health care. I'm not paying that service that the hospital has to have or something. I don't know how that works, but it's rather than a fine, I'd like to look into some type of just recoup expense type of situation.
I think that's something to look at and something to suggest, but I think that, across the board, it varies from hospital to, and I'll just use my office as an example. My MA bears the brunt of that when I give her the prior authorization. So that varies from office to office, but it's something to throw into as a thought with what we might do. Anything that takes longer than X amount of time, then there's some sort of recouping the time. Okay, committee members, anything else? Representative Ward.
Thank you, Mr. Chairman. I'd like to see us increase competition so that more insurance companies could be able to practice or offer services in Wyoming, or alternative means of care like co-ops. What are the barriers to them entering, and can we remove some of those barriers? More competition would mean that providers that aren't serving the needs of their patients would be sought less and eventually out of business. I'd like to see more competition if we can help that somehow.
Senator Dockstader, go ahead.
It says, I think we all would, but there's only 500,000 of us here. I think we'd all like to see a little more. There's only 500,000 of us here, and so appreciate them doing business in Wyoming now. So unless we get creative with over state lines and things like that, that's a tough call, but I appreciate what you're trying to say and do, but that's a tough one. We're just not a lot of us to make it happen financially.
I think that's another subject of perhaps to contemplate and talk about. It won't necessarily fit with this bill, but it's something to talk about. Something we have talked about in the past, frankly. Okay, if there's nothing further, you have enough. Senator Dockstader, Representative Penn.
And then are we author?
Go ahead.
I guess, Mr. Chairman, are we authorizing them to have a meeting? I just want to make sure they get paid and have per diem and salary to have a one-day meeting with stakeholders.
That would need to go to Management Council to have that approved, but yeah, I would propose that.
Coming out of our budget.
Yeah.
Sure, we'll ask.
Mr. Chair,
Senator Hutchins?
I know you kind of glossed over it, but Representatives Ward and Clausen had a suggestion that you said we'd get back to later. Are we going to address that?
We will as soon as my finger
Thank
works
you.
on the mic, but we will get to that. As soon as
Thank
we
you.
complete this particular subject, then we're going to go to that one.
Are you asking for more topics still? Can I throw one more on?
Sure, go ahead.
This is on the top, just retroactive denials. So once approved, you can't deny. I think we talked that none of the three companies here believed they were doing that or knew they were. So at least making sure that's a discussion to.
And that's the other point I would make, to make sure the stakeholders here, the three companies that are here, there's other companies that aren't here. And we all know who they are. We're not going to go through the list of names, but we need to make an effort to get them involved as well. Particularly ones we talked about, Medicare Advantage companies that are working with that. That's only two companies, I believe. But anyway, we need them in the conversation as well. Okay, Representative Penn, Senator Dockstader, does that meet what you need? Okay, so that will go ahead. You will have a meeting, perhaps before you leave here today. You can get together with these folks and plan a date. My co-chair will get with Management Council, and he's doing it as we speak. Yeah, so he will know. So we don't want you to go away poor. Okay, we'll do that, plan a date. And when you have something together, let's put it in format, send it to the committee by email. We'll approve it or say, what were you thinking? And we'll get it in LSO format. We'll have it for our next meeting, for our June meeting in Evanston. Okay, with that being said, other topic, Representative Klaus, actually Senator Barlow.
Mr. Chairman, so I requested a bill draft be prepared for the next meeting that would limit the look-back period to 2 years for an insurer to try to claw back. I don't know what all the right terminology is, 2 years. To be clear, Mr. Chairman, I already actually requested this as a personal bill, but we'll just transfer that to a committee bill if the committee is so inclined. Thank you.
Okay, that first and second, any comments on that, Representative?
Thank you, Mr. Chairman. If I might add that PBMs be included in that.
Discussion committee.
Second, I second that.
How would that look? How would that, go ahead, Senator Barlow.
So, Mr. Chairman, I haven't looked at the actual statute that it's currently contained in, so I think we're just talking about insurers. If a PBM is an insurer or an agent of insurer, it would seem they'd be automatically included. But we'll let our staff do that preliminary work and some background on that, and I think that would be appropriate. But the interest is noted. I appreciate that, and certainly I think our staff will have to do a little bit of look at that to see that they are included. Thank you, Mr. Chairman.
And I would say with research, when I come back, when we do this on our June meeting in Evanston, that if that's something that would be appropriate or needed, then we can deal with amending it in. Okay, committee, any further comments, or shall we vote? All in favor of that motion by, yeah, by Senator Barlow, say aye. Aye. All opposed, say no. That is unanimous. We will have a bill draft on lookbacks. Okay, thank you very much for that good work, committee. We are only an hour and a half behind schedule, which is not bad for labor and health. That being said, it's 12:05. Let's go have lunch and be back here at 1:10.
Is that okay for the people?
Mr.
Chair, really quick, Mr.